I'm there, but my bandwidth is low. Probably video is not coming up. Okay.
Hello, Dr. Maipal.
Hi.
Hi, Maipal.
Hi, hi.
Hi, Ram.
Hi.
Good evening, Dr. Ramurthy sir.
Hi,
Dr. I need to leave by 7.
So your talk is okay. Your talk would be done by then.
Okay. Yeah.
You can't join back?
Ma'am, we are live.
Yeah. A very good morning, good evening to one and all of you. Refractive webinar has had a long wait in our ARC webinar sequencing, but then we are here today with a potpourri of very relevant and need to know aspects of refractive surgery to be addressed to you on the best platter. We are lucky to have the top cream as refractive surgery is concerned on the expert panel. Our president, Dr. Mahipal Sachdev, our past president, Dr. D. Ramurthy, Dr. Sri Ganesh, chairman and MD of Netradama Group of Eye Hospitals, our honorary secretary, Dr. Namrata Sharma, our scientific committee chair, Dr. Partha Vishwas, Dr. Rupal Shah from CFS Baroda, Dr. Himanshu Mehta from Mumbai, Dr. G.S. Dhami, IRSI president, to discuss threadbare all the topics in this forum, and I'm sure all of you are going to enjoy. Dr. Praveen Krishna, the leading light of LVPI, would be moderating along with me. Thank you, Dr. Praveen. So without any ado, we shall go on to our first enthusiastic refractive surgeon from Pune, who would set the ball rolling with a review of literature on why PRK is superior to flap in a 500 micron cornea. On to you, Varma.
Thank you, ma'am. I will just share my screen.
All of us have to remember that our talks are for 5 minutes, and at 4th minute, Mr. Sunil will give us a warning, and we should close by 5 minutes.
My screen visible?
We can see it.
Yeah, okay. First of all, thank you, Dr. Chitra ma'am. What I'm going to speak to you about is going to be some review of literature about why the PRK or surface ablation is superior to Lasik procedure in a thin cornea, which is 500 micron. Friends, we all know that basically when we are talking about 500 micron cornea, we are specifically looking at the safety aspect of the refractive procedure amongst the predictability, safety, efficacy, and stability. The safety becomes of paramount importance in this regard at this thickness. So the burning questions are, does the thinner cornea mean a biomechanically weaker cornea inherently? Does PRK induce less biomechanical weakening as compared to LASIK procedure? Is PRK so in turn inherently less prone for ectasia than LASIK surgery? And what about safety, predictability, efficacy, and stability of PRK in thin cornea in general? So does the thinner cornea mean biomechanically weaker cornea? As we all know, in refractive surgery, when it comes to the newer way of investigating these patients preoperatively, the biomechanics is playing a very big role. And this has been shown time and again by variety of studies that generally the central corneal thickness and the biomechanical parameters, they correspond. Of course, we have always seen exceptions to that, such as having people having 550, 600, even 570 micron cornea with keratoconus. And we have also seen, on the contrary, about 460 micron cornea, which have been stable in long term. But generally, yes, the thinner cornea means that probably a biomechanically weaker cornea. So does the thinner cornea mean a higher probability of ectasia after corneal refractive surgery? So I think this factor has been looked at time and again, and low preoperative corneal thickness has been seen to be a significant risk factor for ectasia in general, especially in the ectasia risk scoring system by Randleman et al. They have seen in their cohort of patients when patients had less CCT preoperatively as compared to the cohort which had normal outcomes postoperatively, the thinner cornea was a significant risk factor. Of course, the thinner cornea is a risk factor which is probably much below the most important topographical pattern, which is most probably the most important factor when it comes to the possibility of ectasia. The third question is that does PRK induce less biomechanical weakening than LASIK surgery? So yes, intuitively, as we understand that in PRK, as against in LASIK, we do not have a flap. And the studies have also already shown that the flap itself does not contribute to the biomechanical strength post LASIK per se. So in PRK, definitely we are preserving more cornea. Uh, the the specifications such as residual bed thickness and the PTA score has been more in term with LASIK. But even if we talk in general, definitely in PRK, we are actually managing to keep a more stronger cornea behind. This has been seen by a variety of published literature already, which have looked at the Corvus as well as ORA studies in which they have shown that PRK definitely is much lesser invasive than in LASIK when it comes to the biomechanical stability in post-refractive surgery eyes. So is PRK also inherently less prone for ectasia than in LASIK? Definitely, there are much lesser reports of ectasia in PRK. So this was one meta-analysis which looked at this, and they have seen that out of 31,000 eyes, only 9 eyes had developed post-PRK ectasia, which was 0.029% of incidence, versus post-LASIK ectasia has been seen to be reported from 0.1 to 0.66%, so substantially higher. And again, a variety of reasons have been given for that regarding the same, including keeping the better strength, tensile strength, not touching the anterior stroma too much by not cutting the flap. And of course, what has also been seen is that apart from much lesser reports of PRK, whenever the ectasia has been reported in PRK,
1 minute left.
Majority of this ectasias have been reported after the first year. So only 10% had represented in the first year, as against in LASIK, more than 50% actually have presented in the first year itself. The most important thing is this contralateral case report. There have been 3 case reports in which one eye has undergone LASIK and the other eye has undergone PRK. In this procedure, the LASIK eye actually went on to develop ectasia and the PRK eye did not develop a full-blown ectasia. In one of the first published reports by my mentor, Professor Kalikaris, then there was another report from Middle East by Zavedi et al. And one of the best documented reports is from India by Dr. Prema Padmanabhan Madam. And as you can see very clearly, this was the preoperative scan of this patient. In the right eye, there was this superior-inferior asymmetry. The left eye actually had much lesser asymmetry. So they actually performed a surface ablation on the right eye, and they performed a LASIK procedure on the left eye with a corneal thickness of 500 micron. And the left eye actually went on to have a full-blown ectasia, where the right eye actually, much stable results. My last slide is basically the PRK has, in thin corneas, has also shown a great amount of safety, stability, efficacy, and predictability as compared to PRK in normal thickness corneas in this 10-year follow-up study, which was published by George Aios. But of course, the last thing is that if you have asymmetric steepening or skewed radial axis, high myopia, residual bed thickness less than 400 micron, then today, even if you have a 500 micron cornea, phakic IOL should be your procedure of choice. Thank you very much for your kind attention.
Thank you, Vartman. You were concise and brief and told us all. One question I would ask is, what would be your upper limit for doing PRK in a thinner cornea?
So, ma'am, I want to leave behind 400 micron cornea. So my upper limit will depend on how much ablation I have to do. So I typically don't go beyond -8 diopters in surface ablation per se, generally speaking. So I have to have that marriage of the amount of spherical equivalent that I'm trying to treat and leaving behind 400 micron cornea at the same time also. So I think whatever the equipment allows me to do, I will go for that.
With a -8, what is the duration of mitomycin which you would use?
Ma'am, for -8, I'm using 30 seconds as the duration for mitomycin C. Otherwise, for myopia less than 3 diopters, I'm using 12 seconds mitomycin C.
Dr. Praveen, you have something to add? Because I think there is some issue here about different timings for many of us. I would, of course, prefer to keep it to -5, and very rarely, there's no other option, would I even consider a -6. I would, I normally would keep it at 30 seconds, mitomycin. But I think Dr. Praveen is on. Are you there?
Yeah, I'm here, Chitra. And
I think you have yeah.
No, thanks for the question. We've actually looked at our results over 11,000 cases, myopia up to -12. And when we looked at the results of PRK and high myopia, 0 to 3 diopters of myopia is equivalent to 6 to 9 diopters. There's no difference in the visual outcome or the stability. Between 9 and 12, the accuracy is a little lower. The stability is a little lower. So I think up to 9 would probably be a safe limit. And mitomycin C, we use a sliding scale, 1 diopter for every 10 seconds, and that seems to be working very well.
Anybody else in the expert panel have anything to add on this?
Vardhan said that you need to have 400 microns left. So if you have a 450 cornea, because her question, Chitra's question was, what is the least corneal thickness that you would take? So if you have a 450 cornea and a -4 diopters, would you do it?
No, sir, definitely not. I think less than 480 microns, I would probably.
480. Your cutout is 480. That was
my
what.
cutout is 480 for such a application.
Okay.
I mean, you can't definitely be hard and fast in that rule because it depends upon the age also. If you have an elderly patient with perfectly normal symmetrical topography, then even 450 microns is fine to treat. I mean, so you have to consider all the parameters before taking a decision. And I think above 350 microns also is fine in elderly patients. If they are over 35 or 40 years, then the cornea remains quite stable.
Yeah, I think I will agree. If it is probably younger female, then I think it is better to be more, let's say, preventive. And if it is an older male, probably you can go further than the statistics.
Thanks for mentioning this because people do it but don't want to mention in a conference. I appreciate what you taking the lead to say that. I appreciate what you're saying. That's exactly.
And even mitomycin, see, it depends. Like if I have a post Lasik or post smile patient which I have to enhance, then we don't necessarily go by that rule. And I generally like to use mitomycin for a longer period of time because the haze is more. Yeah.
Yes, I agree.
For me, the take-home message from this very nice review is that if in doubt and if you still want to do LVC and the patient qualifies for it, go for PRK. And we have Lasik, we have Smile, etc. But as far as safety is concerned, still PRK is the king. And in case you are combining it with collagen cross-linkage, still I think that's most scientifically, intuitively right. And for us, we use mitomycin C for 30 seconds, irrespective of the amount of power that we are treating. And it has worked well for us and with hardly any documented side effects and very little haze.
Chitra, I am audible.
Yes, you are audible.
Yeah, my fault. See, I think the first important step is how you really remove the epithelium, whether you're using manual or alcohol or viscoelastic or it's a trans-PRK. Then how really you use mitomycin. Any spillover from the cornea is going to give you a trouble, whether you use it for 30 seconds or whether you're using it for extra second. And that makes the difference. The complications do not occur because of PRK. The complications occur because of more of the chemicals we are using to complete the surgery of PRK.
Yes. Any other questions before we move on to the next talk? Dr. Praveen, you have anything to ask?
No, I think most things are covered, and in view of time, we will probably move on to the next talk. And for the next talk, we have our young, dynamic chairman of the ARC, Dr. Chitra Ramurthy, who is going to be speaking to us about why SMILE is a better bet compared to traditional methods of laser vision correction. Dr. Chitra.
Thanks, Dr. Praveen. At the very outset, in the background of the differing technologies which are there and contesting and competing with each other, it seems relevant that we have an evidence-based understanding of why SMILE stands strong amongst them. Essentially, there have been hurdles here. There is a lack of uniformity in the reporting outcomes. There are lack of RCTs, and the meta-analysis are of low quality. However, the comparison of SMILE against Lasik is going to be compared in these 7 segments. Going further, it is seen that in different meta-analysis, the refractive outcomes when you compare SMILE to Lasik is equally efficacious and equally predictable. But there are certain limitations in SMILE. We all are aware that there is no tracking device or registration, no cyclotorsion compensation. And the treatment here, unlike in eczema, which is centered on the pupil center, here it auto-centers on the visual axis. However, said there, a small difference in the pupil center and visual axis does not indicate a decentered dot. So the next important thing, we need to look into the astigmatism. We do know that undercorrection of astigmatism is a bit of a bugbear in SMILE, but then in any other procedure too, it depends on the magnitude of cylinder correction, the presence of angle kappa, if there's significant ocular residual astigmatism, the head positioning is not appropriate, the docking is not done well, and if the lenticule extraction is not complete. But keeping this in mind, different proponents have come forward to tell us that there is 10 to 12% undercorrection of SMILE which occurs more so in higher grades of astigmatism. But having said that, a comparison was done between SMILE and femto-Lasik in different studies which showed that there were undercorrections even in femto-Lasik, and this was not statistically different. However, suggestions have come up about manual compensation, triple marking centration, the consideration of 10% increment in the refractive cylinder value which was entered, which could be made as a standardized treatment protocol. When we talk of manual cyclopotassium compensation with a triple centration technique, you have the patient sitting on the sit lamp and you mark the 3 o'clock, 6 o'clock, and 9 o'clock positions. And then you have them when they lie down. When you dock, you ensure that the reticule comes to overlie the 3 o'clock, 9 o'clock position. But again, that although the results have been promising with lesser induction of higher order abrasion or spherical abrasion, in higher grades of astigmatism, there is no head-to-head comparison again. But the most effective role which SMILE plays is in the effective optic zone which it offers. We all know that in eczema, there is a peripheral energy loss and it becomes a smaller functional optic zone with induction of spherical abrasion. And we all know that the effective optic zone size determines the area of greatest optical quality. And this is definitely reduced in femtosecond laser, Lasik as compared to SMILE. This was an older study where there were 100 eyes were compared for PRK, Lasik, and SMILE by Dan Rainston with equal pachymetry thickness and flap or cap equal thickness. And he professed that the SMILE was biomechanically stable. This probably encouraged the refractive surgeons to think that since SMILE lenticule is being removed from the deeper stroma, which definitely contributes less to the biomechanical stability, that we could probably treat higher myopic errors. But largely, after understanding that our biomechanical tools are not that optimal, we would not try to treat more than -9 diopters even if we are doing a SMILE procedure. There were various studies which have come forward to claim with the existing biomechanical tools that the SMILE works favorably. We do understand that SMILE has a theoretical advantage of less weakening effect. It has inherent stronger biomechanics. And if you were to combine SMILE as a SMILE extra in some of these eyes at risk, the CRF has been found to be better. And the CXL has been found not only to cross-link the underlying stroma, but also the overlying cap.
1 minute
and the evidence of cross-linking is there, which gives it an extra edge. If you look at the ectasia, there have been very few numbers in meta-analysis, and some of these eyes were where preoperatively it was not noted. However, there were many papers which come to claim that PRK strands better biomechanically, then comes SMILE and then Lasik, but these changes are too subtle to warrant a change in the screening criteria. Confocal microscopy again seems to show that there is some amount of stromal reaction in some of these eyes earlier on, but these were more in those learning curves where there was a variability in setting the energy parameters and the surgeon's skill. But something which stands to remember is that there's a large vertical cut which we are doing a femto-Lasik flap against the 3 millimeter to 5 millimeter cut with the SMILE incision. And this definitely ensures there's a less cutting of the nerve plexuses, and there's definitely less dry eye. In fact, there's a recovery of dry eye status after SMILE within a month as against a barren appearance with femto-Lasik procedure. Again, at different time points, when you look at the tear breakup time or the subnapasal nerve plexus or the corneal sensitivity or the tear osmolality, in all of these, SMILE scores over Lasik. If you look at the enhancement again in Lasik, it's 5 to 28% and just about 2.9% or less in SMILE. And the risk factors in SMILE are essentially patients over the age of 35, higher than -6 diopter, high astigmatism, and those who have had an intra-op suction loss. And again, there are wonderful options which are there to consider if you're doing a SMILE enhancement. The most important and the last is that much discussed is the SMILE versus Contura. And there was one big study done by the Canalopolis where he claimed that Contura seemed to do better than SMILE. But we did a prospective study of 400 eyes, wherein we found that both of them were equally predictable, equally safe, and equally efficacious. In fact, we looked at the higher order aberrations. The vertical coma was just a little more in SMILE, and the spherical aberrations just a little more in Contura. In other words, the results seem to be equivalent. The residual error is the key factor. But most importantly, post-operatively, all patients who underwent SMILE seem to be more comfortable. So I would like to conclude stating that yes, SMILE is an excellent, safe, and predictable modality with immediate comfort and lack of dryness. Biomechanically, superiority seems to be likely, but that needs yet to be established with better, more sophisticated tools. Thank you.
Thanks a lot, Chitra. Lovely review of why SMILE is potentially better than LASIK. So if you have a patient in your clinic and you do both LASIK as well as SMILE, who asks you to make the decision for him if he's suitable for both LASIK and SMILE, what would you tell that patient?
Definitely, if in every way, if a patient is suitable for refractive surgery procedure, I would definitely advise him to undergo SMILE. The cost would be the only reason where I would open up more on the other options. Of course, all the options are equally discussed to the patient, but I would be more favorable for doing SMILE because I'm quite convinced that it is quite safe and there's an immediate recovery. And I would definitely, although I do agree on PRK being a treatment of great standing, but that initial discomfort which is there has to be kept in mind. So I would consider it more for those borderline cases wherein I would not suggest the other options. Femto-Lasik, by the very fact that vertical cut is there, I would definitely keep it as a secondary option.
Perfect.
Madam,
Thank
I had
you.
a question
And
for you. Can I? Yes, sir.
yes, please. Rupa.
Madam, if there's a borderline dry eye patient, would you do SMILE and not LASIK?
Borderline dry
Because the risk of dryness post SMILE is much lesser. In which cases of borderline dry eye, would you do SMILE and not LASIK, or would you not do both?
No, I would do SMILE against Lasik.
In which cases, madam? Like, for example, there are cases where we would reject the patient outright.
Yeah.
But in which cases would you do SMILE but not LASIK?
I would do SMILE for all patients unless, of course, the dry eye is significant, then I would need
Only
to
dry eye,
eye,
with respect to dry eye.
or there is some kind of a biomechanical, I feel it's a thinner cornea or those. Against femto-Lasik, I would advise SMILE, excepting high cylinders.
No, ma'am, only with respect to dry eye.
No, with respect
Everything else being the same.
Yeah, with respect to dry eye, there's no doubt SMILE would perform better than femto-Lasik. There's so much of cutting of nerve plexuses, there is no way I would suggest femto-Lasik as against SMILE.
The other point I wanted to just discuss is that when we talk about biomechanics, we always talk about ectasia. But I think ectasia is more because of a pathology in the cornea. These are abnormal corneas. But when we look at biomechanics in terms of long-term stability, and you look at both LASIK and SMILE and the enhancement rates, we find that definitely with SMILE, the stability, long-term stability is much better. We have done over like 8,000 procedures now with SMILE, and our enhancement rates are just like 0.2% or so. With LASIK, it was 2.5%. And I think Rupal also has published, because she was one of the first to start SMILE. She's got probably the longest follow-up, and I'm sure she can also talk about this. So when you talk about biomechanics, it's also the long-term stability of the cornea rather than just ectasia.
Yeah, I agree with Dr. Sri Ganesh. When we talk about biomechanical strengthening, it is not just in the form of having ectasia. Ectasia per se is really in a very, very minuscule percentage of cases of all refractive surgery cases done all across the world with different platforms and different procedures. So ectasia is not the only thing that you are worried about. You're worried about the long-term stability. And definitely SMILE scores better. In fact, Dr. Chitra, I would, if there is a high cylinder, I would want to do SMILE rather than femto-Lasik, because I found the results to be definitely superior in terms of the stability of the outcome that you get. I also wanted to ask you, Dr. Chitra, is that one of your slides said that there is more danger in older patients, and is it something like that? I mean, why would you be more careful in older patients or males. There were like 3-4 points, and I didn't really get that.
What did you say? I didn't hear you. Older patients?
Yeah, one of your slides said
So
that you
enhancement rates has been seen that are very few in SMILE, and that too it has been seen in patients who are older than 35, or if they have a myopia more than -6 or a high cylinder, or if they've had an intra-obstruction loss. These are the situations where there has been those limited enhancement rates. Praveen, question? Any other question?
So anything else from the other panelists, Dr. Mahipal, Dr. Ramurthy, would like to add, Dr. Himanshu, Namrata?
Can I just ask a question to the panel right now?
Yeah.
Absolutely.
Tell me what is the, I think the amount of dryness for Lasik has been overstated. Your cataract patients, all your cataract patients, how many of your cataract patients complain of dryness post-surgery?
We actually
With a
add
2.2 millimeter incision at the limbus or maybe the cornea, we have more patients complaining of dryness than in fact routine patients. I just want an answer from the panel. What do you think? You agree with me that it's being overstated?
Dr. Himanshu, that could also be because we're giving a lot of drops post-cataract surgery for a longer period. So that could also be because of that, and not just the incident.
And also the age group. If you look at the age group, the
Yes.
cataract patients are the older age group.
Older
And many
age
of them are postmenopausal women who naturally have dryness. So you can't really, it's not a comparison of apples to apples. It's like apples and oranges. So you can't really compare the two groups.
All right. Dr.
So
Chitra,
any
we
other
should probably
question,
move on.
Ramurthy? You have anything to ask? Gaurav? Then now Dr. Namrata, warm welcome. Anything to add before we go on to our next speaker?
Thank you, Chitra. Nice talk.
Okay. Dr. Kumar has yet to join us. So Dr. Rohit, I think you should share your screen. And Dr. Praveen, could you introduce Dr. Rohit?
I don't think anybody needs to introduce Rohit because I just will probably say welcome, Rohit. And Rohit is going to be speaking about the reason why Contura probably scores over other forms of LASIK. Rohit, over to you.
Thank you, Praveen, and thank you, ma'am, and the RC, and all the panelists and dear friends watching this. This is a full one-day session, but I will try to summarize it in 5 minutes, and then we can have a discussion with financial interest. The entire Contura is basically driven from this concept. The concept about the curvature is not just only the curvature, it's not just astigmatism, it's a mix of a pie chart which mixes the higher and lower order aberrations. And this is not, I'm not talking about keratoconus, I'm talking about the normal patients. So how you correct this is different from how you correct this. And that's what the Contura is completely based on. And what we see when you look at a topography like this is a cylinder, epithelium, how your ablation pattern is, everything is completely hidden, which we don't see. Now, more and more as we keep moving on, we start looking at aberrations and what we need to correct from every aspect of it. The epithelial zernica and epithelial aberrations is totally taking up a major role now because it determines how your anterior and total is, and of course, how your lens is actually behaving to a certain accommodation. And for example, you can see that the epithelium itself contributes to some amount of astigmatism. So what I've done is I compiled some articles of our own work, which some of them are published and some of them are in review, on what Contura is different. These are all the groups, just to say it's safe. And you can see that the line of gain of lines, and this any machines will do. And you pick up any machines today in 2020, every machine can give this kind of a picture. And this is something good, but what is important is the depth of focus, because it induces less Q value, minimal higher order aberration. Depth of focus was not something which was studied very extensively. And today, in today's context, let's start with today with lockdown or no lockdown. Depth of focus is probably the most important for a young refractive patient who wants to come to you, because it's taken as guarantee that 99% of us who do refractive surgery get that 6/6 20/20 vision. Very, very difficult now to give you a less vision with the machines what we're using. But what is really the new factor is the depth of focus. And that's what we looked at it. And that depth of focus, what was make me the most important selling point of Contura today. How does all these concepts of depth of focus and all the quality of vision, of course, I'm not denying that there is a quality of vision. Chitra ma'am rightly said there is a different quality of vision with all these procedures. And more or less, I don't want to even debate on this. Every machine gives you the same thing. But one major selling point for me is we did the study and that's got published. We compared with many other platforms, and the paper will be online, and it just tells you how important it is. How is this the real future? Is looking at all these factors. Now, most of the modern machines, including Contura, don't look at your epithelial profiling, and that epithelial profiling has to be built in the future generation of laser surgeries. Because in this case, you can see that this epithelium is in this kind of a cornea, which looks perfectly healthy, but you still have a close to 0.75 diameters of cylinder, which is contributing to your aberrations. And that aberration, it's contributing to a significant amount of coma and trefoil. And this is a very important factor. And we are not treating this, we are going deeper into it. It's a very important factor to be considered when you're planning a refractive surgery or Contura in the future, because these are all the few things which will probably go into it. And we now are assuming that everything which is in the aberration platform has to be knocked off. It's like we look at them as a culprit, a jail culprit, and everything has to be knocked. But
1 minute left.
I feel that these things are more like a commensals. A commensals, I call them the commensal aberration. We need aberration to have a proper health and depth of focus. So we started looking at which aberration needs to be looked at. Now all this looks at research, but in future, all these machines can be customized. You can knock off only ones you need and keep the ones you don't need to treat. And this, I think, would be the real future of customization. And this is something which is just, and this we just launched now. It's a new software, Oculus, and we have joined. It took 7 years to build it. A lot of biomechanics machine and future topography machine will have it. It is the first artificial intelligence-based mathematical modeling where you feed in the data. It will tell you you don't need to worry about your biomechanics parameters. It will tell you how much does your cornea get weaker by different surgeries, and you just have to click this. And now we are on a beta testing. Maybe next year it will be there in many of
Time's
the.
up.
And this is going to be the real future of how Contura or epithelial modeling will be. So I just took a little bit insight into digress into what the future is, but what Contura is for me is a better control of aberration. I don't say that it clears aberration, it controls aberration better, depth of focus, and the future is going to be on the use of simulation on AI and use of epithelial maps. Thank you.
Thank you very much, Dr. Rohit. I know Contura cannot be discussed in 5 minutes. There's one question I have. Like largely we do Contura Lasik in a normal eye, wherein we feed in the subjective refraction and the subjective axis. Now you have a patient, otherwise normal eye with some higher order aberration, some induced coma, and you would treat it by the topographic axis with the C4, C12 compensation. Can you promise the same refractive accuracy to these patients as you would if you were to do a normal Contura treatment?
Basically,
or would you promise them that you'll give them a better quality of vision, but there might be a small residual?
If you are going to go back into looking at the ablation pattern, when you keep the refractive error as 0, and if your ablation pattern shows that the ablation is 8 to 10 microns without treating a refractive error, then I will tell, and I'm sure that this Contura will work very well for the patient. However, when you keep the ablation as 0, and you have only 2 or 3 microns of ablation for a 0 refractive error, that means the patient does not have any higher order aberration. And this is important because you are not going to do any benefit to this patient. Whether you do this, or of course you will do benefit because you are not going to induce anything. But Contura works very well in a patient who is normal but has higher level of aberrations which may induce some changes. But The most important point which I want to bring in here is without understanding the epithelium, if you are doing a contour treatment, then epithelial cylinder itself could mess up with your reading because epithelial cylinders of 0.5 diopters or 0.7 5 diopters will not going to change even after you do your contour. So there has to be a little bit of optical understanding of this, but still in a normal healthy patient, if you ask me why I want to do it, and this is something which is got published also in GRS, it's the depth of focus. And the depth of focus is what is very, very important for a young person who works in IT or any of this profession.
Rohit, I have some questions for you regarding depth of focus. Okay, depth of focus in a young patient, basically the corneal abrasions contributing or correction of corneal abrasions contributing to depth of focus is very small. Maximum it may be like half a diopter or 1 diopter. But these patients have very good accommodation. They have like 9 diopters or so accommodation with the crystalline lens. So that itself gives a very good depth of focus. So how does this half a diopter or quarter diopter correction actually increase the depth of focus? Because depth of focus in young patients, again, is because of accommodation. So how much does it contribute? How can it make such a big difference is something which I'm wondering. The other question is, see, I have seen so many patients because contour basically is based on treating the topography and the cornea. But I believe that refractive surgery is correcting the refraction, be it with phakic IOLs, be it with Lasik, PRK, or with SMILE. And if the patient has 6/5 vision with glasses or contact lenses and is happy, then you just need to correct the refraction. And correcting the topography itself can alter the aberrations and induce some kind of a difference in the lower order aberrations when you correct the higher order aberrations. So it may be a little off and it may not be as accurate as correcting the refraction. That is my question. And then there are so many patients who have a corneal cylinder, but they do not accept cylindrical power because they have lenticular astigmatism, which contracts the corneal astigmatism. And these patients, you do a topoliink correction, and then they will have residual astigmatism because of the lenticular astigmatism. And this was my question also to Canalopolis, and somehow he said that it gets corrected over a period of time, but we want the patient to be reading 20/20 day 1. So if the patient has lenticular astigmatism and corneal astigmatism, which are kind of correcting each other at opposite axes, then how do you manage it? I mean, how does contour work in such cases? I mean, this is my whole question, because I believe refractive surgery is about correcting refraction. And of course, I would 100% agree if there is an abrated cornea. If there's an abrated cornea with corneal abrasions, keratoconus, where you actually have to treat the abrasions for a therapeutic reason, then topoliink corrections make sense. But for normal standard corneas, I think just correcting the refraction would do well. And if you look at phakic IOLs, where you're not treating the cornea itself, these patients are among the happiest because you're just correcting their refraction. And when you have a normal fitting, you always go, and if ready-made suits fit you very well, you can just go and pick it off the shop because you know what you're going to get. You know the results. When you get a bespoke tailoring, you don't know what you're going to. It may be good or it may be bad. So that's my whole kind of a logic. And I think this logic of using topoliink for normal cornea is a little warped.
I would answer your question from the last question you asked about the whole cylindrical. Absolutely agree with you. And because of the paucity of time, I did not include. There are a lot of software, third-party software. We also build one where you decide not to treat these patients who have a high lenticular astigmatism. I mean, because we know that I call it the group 3. There's one called 4 cities, and we have our own called a 3Z software. So you're right.
So you need to also have an eye trace to look at the internal aberrations, and just doing corneal topography and deciding to do a contour would not help, right?
Absolutely. Because see, what happens is the group 3, which forms group 3 is the lenticular astigmatism being higher, forms 3% of your contour patients. I mean, this is something which we publish, and 3% of them, if you put them in your bracket of contour, they would not work. I mean, 4 cities with Dr. Ramurthy uses gives a different platform. That's a different discussion. So you 100% agree on this. So in these patients, the total wavefront would do well, or just a simple aspheric treatment would do well. The first question is about the second
depth of focus.
Depth of focus. Depth of focus Optically, you have a different answer. In reality, you have a different answer. Optically, if I give you an answer, depth of focus, of course, it improves and all that. Younger the patient is. But where it really helps you, sir, is the patient who complains of end of the day fatigue. End of the day, and some many times we blame it on the dry eye. We say that the patient says comes to you that, and we took this sort of patients and started looking their depth of focus. And we believe that this patient should, I mean, they had a beautiful, you're right, 9 to 10 diopters of beautiful accommodation. We studied on Osiris. But the challenge was that poor depth of focus in them was creating. And the question is, does it happen to everybody? May not. So this depth of focus optically has a different definition compared to what it actually translates on the patient. But having a good depth of focus in different ways, patient may not recognize it, but it may just help them. For me, if you ask me where it really helps them, is being comfortable after 12 hours of working without having any fatigability is probably gives them that confidence. So
But that also depends upon binocular vision and fusion and stereopsis, because there was a study by Praveen Krishna where he compared LASIK and SMILE, and he found that the stereopsis and fusion is much better post SMILE than with LASIK. I think Praveen can also. So then probably the fatigue would be less, right? So there are multiple factors.
I'll probably chip in, but that wasn't Contura. That was wavefront guided LASIK with the older platform. But I think what is important also is for depth of focus is to have similar aberrations in both the eyes is what we found.
Yeah.
If you have different aberrations in both the eyes, then actually you have lesser stereopsis. And so your binocular performance at close as well as intermediate distance tends to go down. So I think maybe the fact that Contura probably corrects aberrations similarly in both eyes probably is what resulting in what Rohit is finding as well about having less fatigue, and also the fact that the depth of focus is better.
I think I would like to just shift gears and make a comment. We have a galaxy of speakers here with a wide experience with various modalities of treatment. For me, it's a 20 happy patient who is more important than 2020. With all these developments, PRK, Lasik, SMILE, I do all of them. I know the positives and negatives like all of you do. But I often wonder whether my patient in 1997, when I started off with Lasik, was much worse off than what I'm finding in 2020. I had unhappy patients then, I have unhappy patients now. Of course, as far as the safety is concerned, understanding correct ectasia, dryness, etc. is concerned, we have progressed quite a bit and we hardly see any correct ectasia. But as far as run-of-the-mill walk in the park case, a -3, -4 diopters, with all the different modalities that are available to us, with all the extra expense that we subject our patients to, has the happiness quotient increased? It's not only in my case, but I have not seen any big published study which says that the patient, refractive surgery patient in 2020 is happier than his counterpart in the year 2000. Comments?
I think what Dr. Ramamurthy is saying is absolutely correct. See, these are, I would say, these are when Zyoptics came in, we were among the first adapters to Zyoptics, and that was for Eagle Vision and 2014 or 2010 or whatever we were talking. And it was basically at that particular time, the aberrometers were not good. And I think it was garbage in, garbage out, in the sense that our Zyoptics patients were less happier than the plano scan of the Bausch and Lomb machine. I think Shiri and Ram would bear that. But all of us started talking about it because it was a marketing thing. And these are all things. See, actually, the best study would be one eye SMILE, the other eye Contura, and seeing the happiness quotient of a patient from a real life situation as to from a real life situation, does he feel which eye is better? And I think Dr. Ramamurthy may bear us out, but I think they have done a study where I think 80 to 90%, or he may be able to tell, almost a very significant majority of the patients felt that the eye which had SMILE, they in real life situation, they felt better than that in that eye.
Yes, that's true.
Can I make a comment, Dr. Ramamurthy? I think it's also we are the culprits. We are putting these thoughts in the patient's mind. We are trying to educate or not actually educating the patients but confusing them into believing one is better than the other. And that plays a big role in the final expectations as well as the happiness quotient that they have. So we as doctors need to be more careful and also more responsible before we actually condemn or praise a technique.
Rupal, you're not clear. There's some signal issue. So we didn't hear your question actually.
No, so I was just commenting that it is us who are at fault because we are increasing the expectation levels of the patients and we are misguiding them about one technique over the other, and that plays a big role in the final happiness quotient of a patient. And I think we all should be more responsible of what we talk and what we give to the patient in terms of education, the so-called education of the patient that we are doing. Also, Rohit, I wanted to ask you, doesn't the epithelium mold itself after any procedure that you do? So would it not matter whether you are going to do epithelial customization, even if you are able to do epithelial mapping, post-op, that epithelium is not going to remain the same. So then how are you going to customize that post-op?
What I said was, if there is an epithelial irregularity, do not try to do any of this topo-guided treatment. You avoid it because you are not going to treat the epithelium, because once you put steroids for 2 weeks with the 2 weeks or whatever, and when you cut your nerves, you would completely change. If you're doing a smile, that epithelium might still remain the same because you are not taking, there's always going to be some hemostasis balance because you're not cut the nerves. But if you're doing a LASIK, then if there is an epithelial issue, then I would not do it. And probably if there is an epithelial change like that, you would probably do a smile surgery because you know there is a hidden ocular surface issue which is creating the epithelium to mess around there. So what I said is I'm not compensating the epithelium at all. I would not do a topo-guided treatment if I see an epithelial issue out there, because that epithelial compensation is completely missed in a lot of our custom guided treatment is what the point I wanted to drive home here.
There's one
Rohit, I would like you to answer this question in the sense that, we started Zyoptics almost together. You are really doing cutting edge refractive surgery today. Do you feel that your patients today are far more happier than what you found when you started off with your refractive surgery?
The question is, see, we are so scared to ask our patients how happy you are.
How happy you are.
We rather be in a bubble that, see, I believe that I'm in a bubble, assuming that whatever I'm doing is getting my patients very happy compared to what I did then. So I would rather be in a bubble and be in my la la land so that.
One thing is definitely clear that we do understand a lot more than we did before, and we feel a lot more happier treating these patients that we are better informed. Whether it translates to better visual outcome, we've not compared patients treated 10 years back with those who come now, because they were happy and these are also happy. One other question, Rohit. They say that in
1 second.
I think they were equally happy earlier also, Chitra. Now also they are happy. Only thing is, I think in terms of
one of the good indicators is the incidence of retreatment. Has it gone down over that? So because the patient's unhappiness is also dependent on where you have got the patients as regards the refractive error and the outcomes. So at least over the years, Ram, I feel that the incidence of retreatment has gone down over the last couple of years. That is the only thing, because maybe the nomograms have become tighter. Maybe we are treating better from that perspective. Otherwise, I think the happiness factor is still the same.
Our limits of treating refractive error has also gone down. Earlier we were treating higher amplitudes, but now we are not treating higher amplitudes. So that also will.
We can choose the right modality for treating even extremes of refractive error. So each one has narrowed down.
I just want to add one point, if madam can permit, so I can then the concept of treating all aberration is like concept of taking care of all bacteria in your ocular surface because it's a bacteria. I think this concept is something which I think has to change. And this concept, because of the optical work, I feel there are a lot in keratoconus patients. When you use adaptive optic to see how much of aberration, what to correct, you'll be surprised many of them want to keep the coma back. If you take the coma off, it's like a phoropter. Adaptive is like a phoropter. If patient actually vision drops. That sometimes that's why when you put a contact lens, some patients actually drop the vision in their keratoconus. That means our understanding of mathematical optics is great, but our understanding on what optics happens on the patient is completely very, very poor. And this is exactly what I told Dr. Sriganesh sir, that mathematically depth of focus is doing well, but how much it translates in the patient on a day-to-day basis is completely different ballgame.
See, the brain also has a filter which filters out the higher order aberrations, be it coma or spherical aberration. There was also a study among Navy pilots who had 6:3 vision, and most of them had some amount of vertical coma. So it's not that all aberrations are bad, and some patients tolerate aberrations better than the others. So it is something which their brain is attuned to. So that is something which is very difficult to decipher, because we basically look at only the optical aspect and forget what is beyond the eyes. But vision is more than just the optics of the eye.
Those Navy pilots had a fair amount of spherical aberration also.
Thank you. We shall now go on to our next speaker. Our next speaker is our eminent Professor Dr. Titiyal, who heads the Cataract, Cornea and Refractive Department of All India Institute, who is going to give us inputs on how to manage epithelial ingrowths. On to you, Dr. Titiyal.
Thank you, Dr. Chitra, and wonderful work from ARC team. Wonderful discussion we had. Let me take you through some of the important issues in the post-Lasik patients, that is epithelial ingrowth. We know that incidence is quite less. It can be around 2.2 to 20%, but the requirement of a treatment in a clinically significant ingrowth can be as less as 2% or less. So that is a good part. And people have described various classification of epithelial ingrowth in post-Lasik patients, grade 1, grade 2, grade 3, depending on the thinness and thickness of a layer. This is a grade 1 epithelial ingrowth, which has a good demarcation line and thin layer. And you can have grade 2, which is thicker. You can say slightly raised lesion in the interface. Sometimes they can cause melting of the superficial flap. That can be grade 3. So these growths can have because of various risk factors. Patient-related risk factor has to be seen, especially people with epithelial basement membrane dystrophies. And Lasik surgery per se, I would say femtosecond laser is better compared to the macrokeratome used in these cases. Poor flap adhesion alignment, intraop epithelial defect can also be a predisposing factor apart from hyperopic treatment in the larger areas. Post-Lasik, I think the flap manipulation or a retreatment is a major consideration which can cause epithelial ingrowth in these cases. Highest risk can be seen within first 3 years of surgery in these cases. And prevention is always better. Preoperatively, good case selection, rule out epithelial problems, dry eye cases. Intraoperatively, femtosecond, as I say, would be better than macrokeratome. If you're using macrokeratome, we should not be using from multiple cases. And if you have epithelial defect, put bandage soft contact lens on the table. Good examination in the posterior period, especially looking for flap alignment in these cases. But most important thing is when to intervene in such cases with epithelial ingrowth, especially those growths which are causing visual disturbances, or they are encroaching the central area optical axis and with a significant induced astigmatism in these cases. Some cases will come in a very advanced stage with a flap melt and they would require initiation of treatment. Timing of surgery should be done if you feel it's encroaching the visual axis within 4 weeks of initial diagnosis. So many cases may not require treatment because they'll be grade 1 or less, and then less than 2 millimeter from flap edge would require observation and see how they do it. You can have surgical or non-surgical alternative for treating these visually significant epithelial ingrowths. Flap lifting and scraping debridement is the mainstay of treatment in these cases. YAG laser can also be primary treatment. Some primarily it is treatment will be flap lifting and debridement, but you can have an adjuvant treatment to especially recurrent cases. Firstly, to ensure the complete removal of epithelial cells, and that can be with ethyl alcohol application or surface ablation, or you can seal the flap with sutures or fibrin glue or a hydrogel sealant can be done in these cases. To prevent keratocite reactivation or activation, you can use mitomycin C, and to have a better healing in a cases of the flap melt, you can use amniotic membrane graft in these cases. Lifting of flap would have chances of recurrence also, around 6 to 44% recurrence has been shown. I'll just avoid the video. Non-surgical treatment, YAG laser is a good option in these cases, which is less invasive, and it can be done in grade 1 and 2 cases. It can be good. It can have complications like Bowman's membrane fracture, or you can have damage to the superficial flap, and subsequent melt can occur. People have used 0.8 millijoule of power with 8 micron spot size. The spot has to be adjacent. At a time, 20 spots can be
1 minute,
given
sir.
in these. So this is a study published by a group, Mohammed et al., where they found that YAG laser application gives you a nice initiation. Like this is our case. The first spot is in the lesion there. It gives a clearance. Bubble can be now adjoining to the another spot, and subsequently that can clear the area of entire epithelial growth. So this is a good way to look into. And if you look into some of our cases, this is one case who had a bilateral total epithelial defect on the table itself with the microkeratome used, and subsequently patient had epithelial ingrowth picture coming. This is the right eye. You can see a significant grade 2 epithelial ingrowth. And the second eye of this patient had a viral keratitis type of picture, which you can see here. Subsequently, patient received antiviral treatment, and after healing of the epithelium, started steroid, and patient recovered very well. But also had a peripheral epithelial ingrowth of grade 1. The important thing here is if you have a patient with a basement membrane dystrophy, you can have epithelial off coming during the microkeratome run. These cases would require a bandage contact lens for longer period. And bilateral, this is a second case where 6 months after Lasik, patient developed a large epithelial ingrowth. So this is a case, there's no demarcation line. So this patient would require a definite lifting of flap and scraping this, and maybe mitomycin C or alcohol to cause proper disintegration of this epithelial growth in these cases. You can see after a treatment here, this is a large pocket of a nest of cells which requires a scraping as such. Just to show one case of smile, which I saw after 6 months of smile, you can see a very small epithelial growth in the superior side, which was actually not hampering the vision. Vision was 6/6 in this patient, good demarcation line. But this patient requires operation. In case this enlarges, we can do a YAG laser in these cases, or there are various techniques have been described in literature for irrigating the interface to loosen the ingrowth. Then subsequently it can be pulled out with the forceps. And use of mitomycin C or cross-linking with riboflavin is described to decrease incidences. The post-Lasik ingrowth can potentially be visual threatening sometimes. Retreatment, re-advancement, or microkeratome use has higher incidence of epithelial ingrowth. Primary treatment is flap lifting. YAG laser seems to be promising in some group of cases. Early intervention may be required. Adjuvant treatment will improve the outcome in recurrent cases. But good thing is majority of cases may not require treatment. Simple observation will do it. Thank you for your kind listening.
Thank you very much, Dr. Tityal, for a detailed talk on within 5 minutes. One question to everybody in the panel and the speakers. When you are removing epithelial ingrowth, would you use isopropyl alcohol alone, or would you use isopropyl alcohol at one stage and then use mitomycin 2? Both? How is it? Opinions of the panel?
Both can be used, Dr. Chitra, because both has a different purpose. This thing, alcohol use will cause loosening of epithelial nest. So you can scrape them completely. And mitomycin C is basically to prevent activities which are going to happen subsequently. So if you have a case which is grade 2 or more, you can use both of them and have a better results.
Yes. Anybody else has anything to add?
One more point about the percentage of alcohol. Typically, we tend to use 20% alcohol to remove epithelium, but for epithelial ingrowth to kill epithelial cells, you need a higher percentage. Ideal would be about 70% because that will kill epithelial cells and prevent them from growing again. And like Professor Tityal said, it would be advantageous to use mitomycin C as well because epithelial ingrowth by itself tends to induce fibrosis in the surrounding stroma. So mitomycin C can also reduce the haze that is there in the surrounding stroma. So it would be good to actually combine the two of them.
Yeah, that is true. I think people are reported 30 to 80% alcohol in these cases. And specifically, you have to take away the epithelium in the edges of both from the flap and the remaining cornea so that you don't have a subsequent epithelial ingrowth. And that has to be done.
I think
One other question. You have a flap melt rarely, epithelial ingrowth, and you need to remove it as a last resort. Why is it does not have much of a refractive impact at all? I wanted the answer from Dr. Tityal. Anybody in the expert panel?
I think that is true. I have also seen one or two patients where we have followed them for longer period, and subsequently the flap melted out, entire epithelial nest came off, the cornea became clear, and patient had a good visual outcome after that. So it also showed that the flap sometimes does not really contribute significantly in these cases as a refractive correction. And even cases where we have done a flap amputation in some cases, despite that, results can be satisfactory in some patients. But I can understand if you look into their induction of astigmatism, higher order aberration will be definitely different and may require a treatment subsequently. Not all cases will behave like that. So these patients do require a subsequent management.
I think ideally a flap is supposed to be planar, and if it's absolutely planar, may not have a refractive impact. As you rightly said, since it's not always so, maybe there are residual errors that are left behind. My question is a little different in the sense that I used to lift flaps for enhancement for even 10 years after the initial treatment for many years. But then about 5-6 years back, a paper came out which said that 3 years afterwards, if you lift a flap, the incidence of epithelial ingrowth is much higher. So any late regression, I'm using PRK, which is obviously more uncomfortable for the patient. As far as I know, it's just one single study which showed that it's almost 8 times more in growth if you lift the flaps after 3 years. I'd like the opinion of the rest of the panel. Do you really feel that epithelial ingrowth incidence significantly increases if you lift flaps for enhancement after for enhancement?
Yeah, I think Ramurthy, in what I have seen is it can be almost up to 50-60% if you lift flaps late for enhancements. Or now I'm doing some of those cases which I've done Lasik. Now they're coming back for presbyopia correction. I'm doing presbyon for these patients, and when we relift the same flap, then we definitely see some incidence of epithelial ingrowth, and it's much higher than if you lift the flap earlier. There are various techniques. Again, one is you can just program a side cut. If you just do a side cut, and that is supposed to reduce the incidence of epithelial ingrowth. What I do is I kind of demarcate the flap with a fine needle throughout, because what happens is when you lift the flap with a Siebel spatula, or if you do a kind of a epithelial rhexis technique, then what happens is the epithelium does not tear exactly at the flap edge, and then there is some amount of overlap, and then if the flap is not created well, then you can have some of the epithelium getting in and then epithelial ingrowth. So demarcating it or using a side cut again would reduce the incidence of epithelial ingrowth. And I always, in such patients, I always use a BCL after the procedure, keep it for a couple of days, and this also I find reduces the incidence of epithelial ingrowth.
Dr. Praveen, you have any other question?
A small question, Chitra.
Yeah, hello, sir.
To Tityal, sir, you showed in the various cases, there were quite a few of the cases in which there was a small superficial, small ingrowth in the superior part, and there was one in which was in the inferior part, very small. So such small ingrowths, and I would agree with what Praveen said, there are certain small boundaries of that fibrotic line that appears in the slit lamp, which can be seen quite well, and also in the anterior OCT. If these small ones are let to be, then usually they resolve over time and do not require treatment, and especially if they are not causing any refractive error or an astigmatism or an increase of astigmatism, then many a times I've had to leave them alone because the patient was not complaining, though we had this ingrowth, and it did not matter to the patient, so we left them. And over 2-3 years, gradually it did shrink. But there was that little band of fibrosis that always stays on. Another case that I want to discuss here is very pertinent. So this is a case in which it was quite a large ingrowth, and we were following it up. It was not causing the patient any difficulty. Then she said that she's not able to see well. Then we lifted the flap, scraped nicely, alcohol 20%, first time, mitomycin C also. Again, a regrowth occurred. Again, we scraped, and again, regrowth occurred. This time we used 80% alcohol, but regrowth occurred again. We were very careful that we took the edge of the flap also and scraped that part, because that is the place where the ingrowths usually occur from. There has to be one place where it is occurring. So we scraped that. But again, now it has recurred. Now, patient is not unhappy with the vision, so we are letting the patient be after the third time.
Also, most of the time, the recurrence of regrowth is happening because we allow the new epithelial cells to get into the interface again. So it is very important after you scrape out and use your alcohol or mitomycin C to have a very nice apposition of flap with the cornea. For that, you would have to put a sutures so that there's a complete apposition. If you have access to other sealants, that should be used. Use of bandage contact lens is quite controversial now. People have reported, some people have found that it is good, but many people have said it's not going to safeguard the recurrence happening in these cases. It is the apposition of the flap which is very important in these cases, so that the new cell doesn't go in. So that has to be taken care of.
So another thing was very interesting in this case. Somehow, though we lifted the whole flap and then scraped also the undersurface of the flap, as well as the bed and everything very well, gelatinous, that epithelial growth that there is. But even in the second time regrowth or the third time regrowth, the edge of the regrowth has not extended. Though we have removed it, and somehow it has not extended. Each time it does not extend, it stays just there and it stays put. So that is something that's quite a mystery. Another thing about Shriganish,
I think,
just one thing that you said about the opening of the flap, the lifting of the flap in the retreatment. So there have been literature in which it says that if a spatula is used to lift it, the possibility of the epithelial cells going in is more. So what has been said is to lift it with a forceps and lift it so that there is no possibility of the epithelium going in, basically. And when the flap is again replaced back, it just grows on.
Actually, it's even been suggested that you can scrape off the epithelium at the edge of the flap so that there's nothing that can grow in, and then lift it up. And of course, place a BCL so that it regrows again. That is also said to this.
See, I think basically there are cases where there is a fistula, where you have a track where the epithelial cells can come in, and usually even after treating it and putting back the flap, it's at the same area that recurs. And there is an area of fibrosis, so it stops short at the earlier area of fibrosis. Now, if you find that there is a fistula, either on high definition OCT or when you lift up the flap, you can see that the edges are not getting opposed well, then you have to suture or use glue. But sometimes they're just isolated patches of epithelium and there's no fistula. Then it's much easier. When you remove these and scrape it off and use alcohol, then usually there is no recurrence. So if there is a recurrence, repeated recurrence, usually there is a fistula and you have to deal with that. And ideally you have to suture that edge.
Yes, thank you. I think paucity of time, we should move on because there are a lot of issues to be discussed. Our next speaker is our president, Aios, Dr. Mahipal, who has definitely brought in vibrancy during the Corona times, a blessing for his tenure, for the different strokes of learning he has evolved for us. He is going to detail us on how to treat flaps dry. On to you, Dr. Mahipal.
Thank you very much, Dr. Chitra. I'll be talking about dealing with flaps stria, and the flaps stria can be classified in various ways, whether it's whether they are microstria, they are macrostria, whether they are fixed folds or they are not fixed folds. So exactly when you are looking at stria, they are wrinkles in the cornea which we see following Lasik. quite often they are small and asymptomatic, and as Dr. Tityal in his presentation talked about epithelial ingrowth, similarly when you are looking at stria, what is very, very important is that is the patient symptomatic, and the stria, are they large enough, and when they are approaching the visual axis, that is something which necessarily one needs to warrant a treatment. Now, the classification of stria can be, as I told you, microstria, which are small superficial wrinkles, and these are usually asymptomatic, and these involve epithelium and basement membrane and the Bowman's membrane only. But if they run deeper into the stroma and they usually cause severe visual impairment, these are what are known as macrostria. Now, what is the etiology of these stria? So actually what happens is that there is a alignment problem between the flattened stromal bed. So normally if we are talking about a myopic or myopic ablation that has happened, so you are flattening the stromal bed, and what is there is that the posterior flap surface is there is a mismatch that happens, and there is a direct correlation with the quantum of tissue that you have removed during the ablation. That means that if you are having small ablation, the flattening would be less. If you are having larger ablation, the flattening would be more, and this mismatch would therefore be more. The second thing which is very important is that the thickness or the thinness of the flaps. These are so earlier when we started the laser vision correction, when folds were a problem at that time, ectasia had not come up. So like a Hansotome, when we started, it was 160 and 180 microns. And we wanted, even for my sister-in-laws, even I wanted that their flaps should be good. So actually I did a 180 flap. So that is that because we didn't want stria and we thought that the adhesion was much better with the thicker flaps. Now, microkeratome flaps are again, which are meniscus flaps, and they cause higher stromal bed irregularities. And when you are looking at the femto flaps, they are at 90 degrees, or you can actually have even an angle which could be more than 90 degrees. So the chances of having stria are much less. Now, in case you have manipulated much more, and there is hydration of the flap, or there is dehydration of the flap, the adhesion and the stickiness of the flap will become different, and therefore the chances of having stria are there. And also it is also important that if you don't iron or if you don't swab the flap into position and wait for it to dry, then these are going to be a problem, and therefore it is essential to observe the patient immediately after the surgery. Now you can see here, these are stria which are involving the central part, and you can often see that the patient comes back with halo's glare, and the patient is always an unhappy patient. As Ram was talking about happy 2020 or happy patient, this will be an unhappy patient, and you have to dilate the pupil and try to look at retroillumination, and maybe an aberrometry can show you that there is a problem. Now, what is the management in case they are detected early? Actually, they should be detected on first day post-operative, even before going. If there are stria, you should send back the patient to the OR and have the thing redone. If it is detected early, you just can relift, hydrate the flap and replace and iron it. And this works only on day one if it is detected much earlier. Now, this is a case of a 35-year-old female, which I have shown earlier also. Lasik was done in 2019, June, developed flap folds. Patient went back, it was relifted and just put back, and the patient was not doing very well. So you can see in this particular case, I am showing you that there is a retroillumination, and you can see the huge amount of stria which is there. Now, what is very, very important for managing these stria is that the adhesion or the anchorage that you have of the epithelium into the folds has to be taken out. So just see, the moment the epithelium is taken out, you can see how macro stria these are, how big these stria are, and obviously this patient would be very, very unhappy. So the total epithelium needs to be removed in this particular case. You have to lift the flap and you have to hydrate the flap. So you can see here that the flap is being lifted. As you lift the flap, you can see you have to, the under surface of the flap also needs to see that it is clean. We are putting hypotonic saline. You can either put distilled water, and you can wait, you have to wait for the flap to actually hydrate. So once the flap has hydrated, that is the time that you have to actually go back and see this. You have to have two sponges which have to move in the opposite direction, and in this particular case you can see that we are taking at about 50 degrees the spatula which we use for the ICC, and we are ironing the flap. So this is a technique that has been described because this loosens the folds that have happened, and this patient I am doing after about a year of the flaps being there in this particular patient. So you had to be very, very aggressive. So the aggressiveness is remove total epithelium, hydrate the cornea with hypoosmotic fluid or with distilled water, and use the back of a spatula at about 45 to 50 degree and try to iron it out. It's similar to a steam ironing of your clothes. If you have to have the clothes, the wrinkles and the creases done, you have to use a pressure there, and you have to have heat which is there. And this is the unaided visual acuity of this patient, who came to 7.5, and patient followed up for some time, and the patient is happy and didn't come back to me. I think the other important thing is that to sum up, I would say that you could also suture the flap which is there, and these sutures need to be placed perpendicular to the folds, and in some cases PTK has also been described, which I haven't done myself personally. Now, epithelial ingrowth presents in about 1.7 to 5.6% of enhancement procedures. Some studies, only one study has reported a very high figure, but the moment you are relifting a particular flap, that is when you have to be extra careful that you don't do excess manipulation and you wait for a much longer time. And as was said rightly, that a bandage contact lens helps in these particular cases, which is there. And epithelial ingrowth has already been handled. So because once you are actually removing these flap stria, because you are relifting the flap, you are removing the epithelium, the chances of having an epithelial ingrowth post stria removals is much higher. And so you could actually look at removing any epithelial ingrowths, etc., or rests that are there. Fibrin glue can be used in these particular cases, which has been shown to reduce the incidence of flap stria. Very few instances of actually implanting the epithelium into the bed in cases of SMILE have been reported, but typically SMILE does not give rise to flap fiascos and such as the stria, micro or macro stria, or also the epithelial ingrowths which are there. So this is the important thing is diagnose flap stria at the earliest, dilate the pupil, do a retro-illumination and do an aberrometry if required, and see how comfortable or uncomfortable the patient is. And you should intervene at the earliest possible if the patient is having discomfort and if the stria are coming into the visual axis. So that is what I would wish to say for management of flap.
Dr. Mahipal, one question. If you have a patient who has come to you after a bad road traffic accident with the flap quite crumpled, there are multiple issues there. Would you try to somehow salvage the flap or would you discard it?
So Dr. Chitra, that's what was said. That has been the experience across the board, that at times, even if you sacrifice the flap, if it cannot, anything cannot be done, the refractive effect is very little. So it will totally depend on the situation the flap is as to whether it is salvageable or not. See, a road traffic accident normally, until of course the flap got amputated, is normally salvageable. Non-salvageable flats are if you have buttonholes, you have tears in the flaps, or you have infections, or you have melts. Those are the type of flaps which you may not be able to salvage, because an RTA, the patient had a good flap and the flap got dislodged because of not even an RTA or even a blow to the wristing or a football injury or whatever it is. So at that particular time, if the flap is there and you do not expect any infection, it is better to salvage. But in case you feel that already there is infection that is coming in, the flap is in a bad situation, then at times you may not be able to salvage it.
One other question. Supposing we know that for a macro striae, we are going to do epithelial debridement and then only deal with it. For a micro striae, it is not the second day, but the patient comes in much later with micro striae. Would you want to do an epithelial debridement, or would you try to iron it out and do the other things?
No, the ironing, see, if the patient is coming back to you, they are not actually micro stria, because they are visually disturbing to the patient. That's why the patient is coming. So under those circumstances, if it is coming in the visual axis and if it is late, there is no way that until, of course, that is what I'm trying to say, be aggressive, because this is what was happened in this particular case, that this case went to a premier institution. The patient was picked up, the flap was relifted, they did they tried to do the stretching, etc., etc. No epithelium was removed. There wasn't any aggressive thing. The patient was back to square one. There are these anchorages which happen. See, there is a remodeling that has happened, and these anchorages of the stroma are very firm. So until, of course, you actually remove these anchorages, swell up the stroma so that then these undulations can go, they will not respond. So if it is a late management, it's only, I would say, the first 24 hours or maybe max 36, 48 hours that these stria, if they are there, they can be taken care by reposition. But if you come on to longer, 3, 5, 7 days or 1 week, etc., it is always better to remove rather than again having the patient to go back to the OR to remove these macrostria or stria which are there.
Dr. Praveen,
Many a time.
Dr.
Yeah,
Praveen?
many a time
Yeah.
the microstria are missed. So I just wanted to give my inputs. My macrostria, the patient's visual acuity is reduced. So patient is unhappy and the vision also drops, and then you have to manage it. But many patients, the microstria are missed because central microstria, especially when you have a thin flap LASIK and you're correcting high refractive errors, you get fine microstria. And like Maipal said, you have to dilate the patient and do a retroillumination examination. Otherwise, you cannot pick it up. It cannot be picked up on OCT also. But the best test for these are the OCAS or HD analyzer, which shows an increased scatter. So even though the patient is reading 6.5 or 6.6, they are very unhappy because they have a high degree of scatter. And this can be picked up in the HD analyzer, and rightly, the epithelium has to be removed for this, and it has to be treated aggressively. Otherwise, you will have an unhappy patient.
And what Shiri is saying is absolutely right. There are patients that I have treated who have gone from one ophthalmologist to the second to the third and fourth, and they have said these are microstria and nothing needs to be done. But the patient is very, very, to the extent that one patient I have recently treated was on antidepressants. The patient was so very depressed कि ये हो क्या रहा है, and the doctors are saying there is nothing, we will not enter. There was a big dilemma. So I said, no, please come, I will treat them. And then there was a big debate because the patient was a very anxious, depressed patient. So under those circumstances, the patient had a lot of discussions. I said, no, please let us not ignore these, because you are very, very symptomatic and you have gone into a situation where you have left your job also because of these microstria, and they were right in the center.
Yeah, if you do HD analyzer, you can typically see the OSI is very bad. Though the patient has 6.6 vision, the OSI will be 5 or 6, which shows that the quality of vision is very poor. That's why they are depressed.
Dr. Praveen, any other question you have?
Nothing from the panel, but then for all the attendees, would request them to put in your questions on the Q&A panel so that we can pick up your questions for the panelists as well. I think also, Dr. Maipal, do you ever use PTK after you divided the epithelium if you have flap stria that don't go away?
See, that's what I said. I have never had the need to do that, but obviously that is written, and I gave the disclaimer that for sake of completion, I told. But yes, in case there are, and that is when the rugosity is not going, the irregularity in the cornea is not going. So you can go ahead and do a PTK. It makes good logical sense to do that. In case they are recalcitrant to you're trying to smoothen them out using all the techniques that I have said. But I have never had a problem in case I have been aggressive enough to treat these stria and do them the way I normally do them.
Just an observation. I mean, post-smile, as Maipal mentioned, the striae do not occur. But I have found some wrinkles, especially if you have removed a high-power lenticule. And this is more because of wrinkling at the Bowman's level. So routinely nowadays, after removing the lenticule, I hydrate and then do a certain amount of ironing from up down, about 8 to 10 times. I do find that this gives a more pristine cornea and better visual acuity on post-operative day 1.
Dr. Praveen, shall we go on to our next speaker? Thanks a lot, Dr. Maipal.
Yeah, I think we will have a lot more talks coming up. So thanks for the excellent talk and the lovely panel discussion. So next up we have
just quickly take a comment.
Maybe after this talk, if you don't mind.
Okay, thank you very much. I'll be leaving. Thanks.
Thank you.
Thank you.
Yeah, so I think comments on flap stria might be relevant to the next talk as well. We have Dr. Sujata Mohan, who is a very vibrant refractive surgeon from Rajan Eye Care Hospital in Chennai. who's going to be talking to us about the next level of flap complications, which is management of free caps.
Outside, I'd like to thank Chitra for giving me this opportunity. And there's a study which was published in JCRS in 2002, which says the incidence of free cap is 0.004% to 1.31%. This was in 2002, and with the advent of femto laser and SMILE, I'm sure the number of free caps we see will be almost nil. But anyway, I'm just going to go through what I would do if I have to deal with a free cap. What are the common causes of free cap? Very flat corneas, deep orbits, large corneal diameters, and also tearing of the dehydrated flap is one of the causes because of mishandling by the surgeon. Incorrect assembly of the microkeratome, poor positioning, surgeon torquing the microkeratome, failure of the stop mechanism or incorrect setting of the stop mechanism, and lastly, a drop in intraocular pressure during suction. There are different types of free caps you can get based upon what is the reason that you have had. I'm not going to go into this. So this is one case which I had in 2004. This is a Moria M2 microkeratome. And as the microkeratome reversed the second pass and I lifted up, I could see there was no flap. Fortunately, I was able to identify it in the microkeratome itself. And when you see a free cap, the best way to deal with them is to fold it, taco it, and store it safely with a drop of saline in some place. And then you can go ahead with your ablation. Here, I just put the saline and tacoed it on the microkeratome itself. And the reason why we have to taco it is to find out which is the right side, which is the epithelial side and which is the stromal side. If you just keep it in a Petri dish, unfolded, then we are going to be in trouble because it's going to swell up and will be very difficult to identify it. And once you have put the right side down, then you can adjust the flap so that you can align the marks which have been pre-placed, as you can see. Alignment is very important because here the free cap is usually extremely round and it will be very difficult to find out the hinge. So it's important that you identify the pre-placed marks and align them well. Also make sure that the gutter that you see is even all round, and you can wait for about 2 to 5 minutes, make sure that the flap is really well stuck, and then apply a bandage contact lens. There are people who would prefer to suture the flap as well, and that is also a possibility that you can look into if you feel the flap is too thin and there's a chance of dislodgement of the flap. So this is another case of a free cap. You can see that, I mean, it was a case which we could hardly expect a free cap, but once the microkeratome came back, you can see that we're searching for the flap and it's not visible anywhere. And again, it was identified on the microkeratome head itself. That is very important. So the most important thing to remember is just look for it immediately. And make sure that you're, see here, I'm just checking to see that it is a nice round because sometimes it can be torn. And this is a very thin flap. So thin flaps are much more difficult to handle. And it's important that we hydrate the interface so that you can move the flap around. Make sure that this is very important because if you leave any gap, then the chance of epithelial ingrowth increases. And also finding the correct alignment is important because otherwise a misaligned flap can cause a high level of astigmatism. So the steps which I've done in both the cases, though the two different microkeratomes are almost very similar, you can actually suture the flap also, which I've done for patients with epithelial ingrowth or after flaps dry, but not in this instance. So the complications of free cap are when the flap is placed upside down. So the best thing would be to taco the flap. Epithelial side is identified by staining. There's a loss of disc, place a BCL over the free cap, suture the hinge. In case of a high astigmatism, reorient. You have to go back, take the patient inside and try to reorient to the correct position. Preoperative marking helps the realignment. And in cases of high astigmatism, in which after realignment, the best corrected visual acuity is not good, then you can go for a topo-guided or wavefront guided laser. In epithelial ingrowth, I think there are several papers on this, and it's very difficult to treat epithelial ingrowth after a free cap because you don't have the hinge, and the chance of recurrence is very high. So I think already it's been dealt with by Dr. Tityal. And again, suturing the hinge or putting a BCL will definitely help. And again, I would insist on a pre-placed mark, particularly when you're anticipating a free cap. And in case of flap, micro and macro striae removal again is difficult in these cases because there is no hinge. And in some cases, probably you might have to replace the flap from a donor, or you can completely amputate the flap and allow the epithelium to grow in. So the tips for prevention are look at the corneal diameter and keratometry in each patient. So make sure that you don't get a free cap. The stopper should be checked before every procedure. Make sure the suction is adequate. Use pre-placed corneal marks, and that's helped me all the time. Patients with very flat corneas, you have to anticipate a free cap and take the extra precaution. And now with the advent of femtosecond laser, I think these patients who have potential for developing free caps should be converted into a femtoLASIK, or you can always do a surface procedure and or do a smile. Thank you.
Thank you very much, Dr. Sujata. Dr. Praveen, you have any questions for her?
None from the panel, but I guess the summary is the fact that if you have a free cap and you suspect one, always examine your microkeratome before you actually start to clean it up or give it to somebody else. So very nice presentation, Dr. Sujata Mohan. Have you ever had a situation where you've lost the flap and you had to proceed with the ablation and you had a good outcome as well?
I've just had these two cases in these 20 years. That's all. I don't have. Unfortunately or fortunately, I don't have them.
Just, I would like to just give one practical tip. If you have not marked the cornea and then you have a free flap and then you have difficulty in identifying, look at the light reflex, because on the epithelial side, the light reflex is usually crisp. And on the stromal side, it is a little, it's not that crisp, it's a little blurred because the stroma, the surface is not so smooth. Whereas the epithelial surface is very smooth. So if you look at the light reflex, you can identify the right side.
Or you can
the flap becomes edematous. I had a friend's case. I had to assist a friend's case, and I found that it was very difficult to identify the stromal side because the flap became edematous.
If you take it out immediately and then inspect it, and that's another very important thing that is in high volume centers. What they do is immediately after the cut is made, it goes for washing and autoclave, and by the time they realize that the flap is in the microkeratome, it's already gone.
Alternatively, you can also stain it with a trypan.
What I do is try to
side will stain with the trypan blue dye, and the epithelium side will not stain.
There are two other tips for identifying the epithelium and stromal side. One is you just touch it with a swab stick or something. On the epithelial side, it won't stick. Well, on the stromal side, it will easily stick. And also, if you do a very gentle scraping on the epithelial side,
little bit of scraping.
On the stromal side, there won't be any peeling off.
Yes.
So just in case you have a problem.
Yes.
Also, I like to leave it in my microkeratome because there is enough wetness. Epithelial surface is up, the stromal surface is down, and your stromal bed is becoming very dry. So it's better that you go ahead and do the refractive portion first and then look at your flap, because otherwise
holding it would really make a difference because you know exactly which side you are on. Just tacoing the flap really helps because then you will be very sure about which side is up and which side is down.
Very rarely a person hasn't done a limbus to limbus orientation and the flap has got rotated. What would you advise about these patients? You see them the next day?
If you mean to say if there is any gap or there is some astigmatism, see, we have to intervene if there is the best uncorrected visual acuity is not good, patient has a striae, or patient is unhappy with the vision. So the orientation in these cases are very difficult because most of the free caps are extremely round. We are not going to get a hinge at all. So definitely we may have to go inside and realign. And you can use those, those astigmatism markers so that they give you a reflex. I mean, this is one of the papers I read about in which they've used the markers to realign the flap, and they've used the reflexes to make sure that the alignment of the flap is good. So this is just a small tip.
Dr. Chitra, I wanted to just chip into what Dr. Rupal just said, that in fact, I like to do exactly the same thing. If I have a free flap, I'll, let it be on the, microkeratome. I'll let it remain there, put a drop to keep it wet and, finish off with the ablation, because the orientation also remains the same and you don't have to kind of, then you just take the head back there and you keep it right next to the eye and, you maintain the same orientation. So the rotation and everything will not happen. I mean, even though you've marked, but still it helps because, you just then slide it back from there and put it straight onto the cornea. You know the exact orientation, how it was cut, and you maintain it. You don't kind of play around with it and take it off and make a tuck or whatever. So I've also found that very useful in those rare instances that I've had it.
I agree with Gaurav. I agree with Gaurav very well about this, and it is very simple. Just taking it very close to the bed and just sliding the flap on the bed. So it is absolutely on the same plane. And the other thing that Dr. Sujata, you were questioned about the rotation. Chitra asked this question about the rotation if the mark is not there. So the the cap is now so precious that I would not like to lift it again if it rotates or does not rotate. I mean, let it be put, and even if there's a small astigmatism, let it be there. So,
no, but it's usually a big astigmatism if there is a lot of disorientation. What I like to do is, if I know that I may not be able to rotate it back and it's been there for some time, what I do is I see the new refraction, let it stabilize, and then this time on, when I'm opening the cap, I mark properly and I make a pseudo hinge so that I can put the flap back in the same orientation as before. Treat this refractive error which is induced now, so that in this new position of the flap, whatever is the induced refraction, that you treat with excimer laser.
Dr. Praveen, we go on to our next speaker. Could you introduce?
Yes, I think we should. And introducing the next speaker, Dr. Gaurav Luthra, who is the president of the ARC at the IRSI. Dr. Gaurav Luthra is from Dehradun, doesn't need any introduction as well. But what some of you might not know about him is he's a fantastic tennis player as well. So Gaurav Luthra is going to be talking to us about treating regressions.
Thanks, Praveen, and thanks, Dr. Chitra and the whole team for inviting me. And let me quickly start. I know you've given us so little time that we have to rush. Okay. So how do I tackle regressions? Regression is a tendency to its original refraction and is dependent on several variables for that matter, but most importantly, the preoperative myopia and the amount of correction. And it's largely due to the epithelial remodeling and to some extent the stromal remodeling after laser refractive surgery, and also much beyond that. All refractive procedures have small differences in their regression rates and their long-term and short-term changes as well. But over a period of time, they tend to become pretty similar. And I actually, in my practice, like to differentiate regression from progression, which may happen due to increases in axial length. So we typically document axial length for all our patients for the last 10 years. And, the patients who have come back after 7-8 years with changes in refraction. And we found that it was due to increases in axial length. And then it becomes very easy to explain to the patient. So keeping records of all patients' axial length is great for yourself and for the patient to understand what's going on, whether it's a regression or a progression, and becomes easier to explain to them as well. Now, this was one nice study that I found, which checked out on the factors affecting long-term myopic regression after LASIK and comparing it to LASIK or surface treatments for moderate myopia. And here you can see that over a period of 10 years, they had divided their groups into the regression group and the non-regression group. And the first A is the LASIK group and B is the surface group. And you'll see that in both of them, it's pretty similar. And towards the end, they kind of match up. And it's about -1 to 1.25 is the total thing there. And similarly, if you look at astigmatism, you'll compare LASIK, femto-LASIK, and PRK. You'll obviously notice that PRK doesn't hold up that well for treating significant astigmatism. For small astigmatism, it's about the same. And LASIK tends to have 80% patients even after a few years, setting up well, and a little lesser for PRK, but I do PRK for astigmatism as well. And this shows you the corneal thickness changes over 10 years compared between LASIK on the left and PRK on the right. Now you'll see a huge change in the PRK. So it's typical that PRK will have more significant epithelial remodeling changes as compared to a flap-based procedure over here, which is LASIK. Now, coming on to a comparison between what we've been discussing, SMILE and LASIK, they stack up pretty much the same. So conclusion was they almost no difference was observed after 5 years, but a regression rate of about -0.02 plus minus 0.39 in the smile group, and a minus 0.12 plus minus. So practically the same in a 5-year follow-up. So this is how, however, the epithelium would differentiate between LASIK and PRK. In LASIK, you can notice that the epithelium thickness changes are there and they reach a particular level. In surface treatments, obviously the epithelium will first be very thin and then it kind of comes up, and over a period of time, you'll see that they come pretty close to each other. Now, why epithelium thickness mapping has become so important of late is because we understand refractive surgery so much better, and you can see that this epithelium is typically around 50 microns. And for patients who come in with regression, it becomes very nice to study the epithelium, because especially if you have the pre-op and the post-op epitheliums, and then you notice some changes happening, it's great to document this. We document it for every patient. Now you can see here the central epithelium being much thicker, and in the post-myopic ablation. Similarly over here, this is a typical myopic ablation, and you'll see how the epithelium forms a meniscus kind of thing over here. Compare that to a hyperopic ablation where the periphery will be, the gut ring is there, and the steps are they're more steep. So typically hyperopia will have more changes in epithelium, both for LASIK and surface, but much more so for surface ablations. And rarely you'll have a surprise myopic epithelium with peripheral hypertrophy, and you will have a surprise and you might feel that you got a significant overcorrection. But if you check out the epithelium mapping, you'll typically know and you will not intervene immediately. Now, for our patients, what we typically do is we see our patients on day 1, day 15, 3 months, 1 year, and then we keep calling them, if possible, annually, otherwise at least once in 2 years, or report SOS. And what we check up on all follow-up visits is obviously the vision and the autoref, which really goes well.
1 minute.
We document the autorefs, the pressures. I would strongly suggest topography at 3 months and 1 year, if possible, and then SOS if required. I would prefer the pentacam because it also gives you the corneal thickness profiles and you can monitor these patients well. And when we need to do, we would typically monitor the epithelium thickness, and we do an eye trace if possible if we notice a regression or a surprise. And we, of course, ask them for a peripheral retina exam, axial length, as I told you. So when to suspect regression? First month, it's more likely to be an undercorrection if you're getting some significant regression, but look at the epithelium. Try to put them patients on topical steroids. At 3 months, typically most patients will stabilize, and then on the annual visits, you can do an objective exam, or if the patient complains. Sometimes they come after many years. However, you should always be on the watch out for ectasia, because in the first 2-3 years, if there's a patient reporting sudden diminution of vision, or if there's a in the first place, they do definitely need the follow-ups. And on autoref, if you see unexplained astigmatism, you can immediately be aware of something going on, immediately do a topography. This is a case which we had of a 40-year-old male, 18 years LASIK done elsewhere, came with diminution of vision for 1 year. And we noticed this ectasia in one eye and inferior steepening in the other eye. This is a long period after the surgery. And of course, the pentacam showed ectasia in one eye. Now, when we took a detailed history, he showed up history of rubbing of the eye for the last 1 year because of dry eye. He was having poor ocular surface. We did go ahead with the cross-linking, but the pearl was that post-LASIK ectasia may happen even many years after LASIK, and eye rubbing may be a cause. So please watch out for ectasia even 15 years after LASIK if a patient suddenly presents with one. Now, if you have a patient with documented regression, ask for a recent history of pregnancy. Excessive near strain. In the last 6 months, we've seen some of our patients who were stable for 10 years coming back with a lot of computer work and a lot of phone use and having a sudden change in their refraction. And this has been one factor. Look for lenticular changes. Look for the axial length changes. Look at the ocular surface. Definitely do an epithelium mapping and a pentacam. Initially prescribe glasses or contacts. Don't jump to operate these patients with regression. Observe them for at least a year or so and then decide what you would like to do. And most patients will understand that this is what they do. So counseling is very, very important. And enhancements, if you've planned, then you could be doing an early, intermediate, or a late enhancement. What's been popular in the past was to lift the flap, but I prefer to do surface treatments most of the times, unless there was a situation where you can do a flap lift. So when do I like to lift the flap? If it's your own operated patient, if your flap data is available, if there is an adequate residual bed, and if there have been no flap complications, and it's a recent previous surgery, and you have a good bed. Now, when we have a lift of the flap, you have difficulty identifying the flap edge if it's been there for a long time, but you can do that on the slit. And which flaps not to lift. If they're ultra thin flaps, 70 to 90 microns, especially if you have been documenting the flap thickness, if it's especially more than 6 months, if there was a flap complication, or if it's been a very, very long duration surgery and the edges are not clearly visible, especially the femtoflaps may be sticking very well. So early enhancements, please lift the flap, and you don't really need to do anything on the surface. Intermediate, which means a few years down the line, flap lifts are usually possible and predictable, but you might want to shift to the surface as well. And if you're doing enhancements after many years, I would preferably go to the surface, because flaps used to be very thick in the past, and some of these patients may have very thin beds, and flap complications may not be apparent over the years. And this is one patient who came up to me looking for a enhancement. She was a young lady, and she was going to get.
You'll have to conclude, Dr. Gaurav.
I was like, so let's go to the last slide. Yeah, summarizing. Early enhancements, you can lift the flap or maybe go on the surface if you have a flap complication. Intermediate, lift the flap or be careful about that. And if it's a late enhancement, please go to the surface. Surface enhancements are gaining more acceptance, and flap lift may be better only for the early first year enhancements if you would like to do them. Thank you. Actually, I didn't hear the call for the last minute. I heard the last minute and then I didn't hear that the time's up. So I was waiting for the time's up to come around, and I'm sorry. We just
It's a thorough talk, very good talk. I just want one question to the audience, to the panelists. Like, do you believe in giving anti-glaucoma medication for early regressions? And if so, how long would you want to give? Anybody on the panel or even Gaurav would answer?
I don't do I'm aware of the fact that it was studied, but I don't do that.
Dr. Praveen?
Well, I do. In fact, there is a publication that talks about using iotim of all drops that actually seems to show that it tends to inhibit regression. But the effect seems to last only as long as you have the drop going on. So it's not something that is therapeutic. It probably is something that is maybe a little prophylactic to buy you a little more time.
I think what it does is it causes some drying and thinning of the epithelium, which reduces the amount of regression. And then this is what is seen. And once you stop it again, it kind of recurs. So generally, I don't use anti-glaucoma medication. Gaurav, I just wanted to know, do you routinely check axial lengths? Is it a good practice to measure axial lengths for all these patients?
That's exactly.
From the medico-legal point of view, to find out whether it is regression or true progression, because it's only the axial length which will tell you and save you also if the patient gets aggressive.
Absolutely. In fact, all our refractive surgery patients get their axial lengths documented at the time of surgery. And then, on follow-ups, if we notice a regression, potential regression or a change in refractive error, it really helps to document that. And patients typically would see that, and you can show them the data. It's very easy to explain to them that if you've had a progression, that it's not really a regression.
What is your take on the extra procedures for preventing regression? Because this was something that has not been covered, and I think there's a lot of it. There's a controversy on whether extra procedures prevent regression.
So I went through the data, and I thought it best not to cover because it's very controversial. And there are data showing both sides of the story. That Canalopoulos has of course shown data on hyperopic Lasik that doing extra procedures may prevent, but nobody else has been actually able to show that. And unless you have something to share, Sri Ganesh.
I think Pavel Studelka also has some data, and for hyperopia, I think it is useful because for hyperopia, it's both epithelial changes and biomechanical changes that cause the regression. So young patients whom you are doing hyperopic treatment above 2 diopters, then I usually cross-link, and I find that it is helpful from 2 to 4 diopters. If you cross-link them, then the amount of regression is less. So only for hyperopia I'm using, yes.
Okay, I'm paucity of time. We have to go on. Our next speaker is Dr. Sri Ganesh, the evergreen hero in cataract and refractive surgery, and he's going to tell us about enhancements with SMILE. On to you.
Thank you, Chitra, and for inviting me to this very nice refractive symposium. So we'll go on to enhancements after SMILE. Are my slides visible? Yeah.
Yes, yes.
So SMILE itself, the long-term stability is excellent, and what we have been seeing is that I've been doing SMILE since 2012 and about 8,000 cases, and our enhancement rate is just about 0.2%. We have treated less than 40 of these eyes with enhancements. So it's extremely rare, but let us look at the enhancement techniques after SMILE for residual refractive error. And generally there are 4 approaches. One is surface ablation, the other is a thin flap Lasik, and then you have the circle software which converts the cap into a flap, and then you can do Lasik ablation. And the last is subcap lenticule extraction, or what is also called re-smile, where you can again do a smile. So coming to PRK after smile, this is the simplest procedure to do, ideal for low enhancements if you have just 0.5, 0.75 diopters. But epithelial thickness to be taken into consideration, especially if you're doing trans PRK, and you'll have to use larger zones. Otherwise, you may not get the adequate correction. And I generally like to use mitomycin C 0.02% for almost a minute. Again, this is controversial because some people say that about 20 seconds, it does not really matter, but the incidence of haze can be higher post-smile and post-Lasik if you do a ablation. And you can see this is a picture showing a faint haze, which you can see, and this actually reduces the quality of vision. And we find that there is increased risk of haze with PRK after smile. But the advantage of this procedure is you can maintain the flapless procedure and the biomechanics. This is a paper published in GRS which showed enhancement of using surface ablation after smile by Walter Secondo and group. And their incidence was almost 2.2% in 2,000 odd eyes, where they did surface ablation and found that it was quite good and effective. Then you have Lasik after smile, and it can be done especially if you use thicker smile caps of 135 microns or more, but most of us use 120 microns. So if you want to do a thin flap Lasik after smile, then 135 microns being used routinely, which Dan Reinstein does, and this is good for low enhancements also. Epithelial thickness, again, to be taken into consideration when you're planning the flap thickness, and femtoflaps of 100 to 120 microns are ideal. There is a risk of entering the previous interface if you use a thicker flap, and the hinge has to be planned to be away from the smile access incision. If you have used your access incision at 12 o'clock, use a nasal hinge. And this is a publication by Dan Reinstein group. He normally uses 135 microns cap, and his incidence of retreatment is almost 4.4%. And outcomes after thin flap Lasik, he reports to be very good. But I think if you're not using a thicker flap, then this is not an ideal approach. This again is an approach which even the company has a special circle software, which is an enhancement solution for smile. It allows the surgeon to convert a smile cap into a flap. And the circle option permits planning and creation of different incisions. And usually there are 3 incisions. One is the lamellar ring, and then you have the side cut with the hinge, and then you have the junction cut. And right now it's not approved in the US, but it is available in India. And there are different patterns for circle treatment. And normally we use the C or the D pattern. And this is the approach which we like now, because with PRK, again, there's a delayed recovery and there is pain. But with the circle software, of course, the biomechanical advantage of a flapless procedure is lost. But the patient satisfaction is quite good, and the results are quite predictable in what we see. So most of the enhancements we do is, this is the circle software where you have the lamellar cut, the junctional cut, and then the side cut. And then you can, it converts the smile cap into a flap, and you can lift this flap. You can see that is how you lift a femtoflap, and you're able to easily get into the interface. And then you can go ahead, shift the patient under the excimer laser, lift the flap, and then you can do an excimer laser ablation. So it's quite easy to convert the cap into a flap with the circle software. There is a little bit of resistance there. You can also use a 2-hand technique. And then that is the
5 minutes
bed, which is done. Okay, I'm almost. This is an article showing by Ektet Chansui demonstrating the, and he says the safety and efficacy of circle software is very good. And Jodh Mehta and group compared the 4 different patterns and found that the D pattern was quite good in rabbit size. They also compared surface ablation, circle software, and You can read the paper, but the last technique is smile on smile, can be done if previous cap thickness is known and can be used for higher refractive error enhancements. Epithelial thickness has to be taken into consideration. This has the advantage of maintaining a flapless procedure. After refractive cut and side cut, the suction is put off. So this is something that the surgeon does. It's not a software in the machine. So you have to put off the suction after the refractive cut and side cut. And the original axis incision is open. The old interface basically is the superficial plane, and this can be easily opened up. Then the deeper plane is dissected carefully and the lenticule is extracted. And the minimum thickness of lenticule should be maintained for easy extraction. So I keep it at 25 or 30 microns. Residual stromal thickness should be adequate for this procedure. So basically, higher refractive errors, 1 diopter or more, you can use this. And centration is critical. Let me just show you. We have done only a couple of cases, and this is the topo pre and then post enhancement. You can see the flattening after enhancement and the reduced corneal thickness. And this is just a short video showing the procedure. So you, after the refractive cut and the side cut, you put off the suction. So you just lift your foot off, put off the suction. Then you open up the original incision, and then you get into the superficial plane, which is very easy to dissect. It's the original plane, which is above the refractive cut which you have created. Then you enter the deeper plane, which is the refractive cut which you have performed. That's the superficial plane. And the deeper, and then you can just remove the lenticule. So this is how you do a resmile, and this was first reported by David Donate, and this is his paper in the JRS. And there is also this paper by George Mehta where he has compared the various techniques and the tissue response in rabbits for those who are of you all are interested. So thank you very much for your attention.
Thank you, Dr. Sri Ganesh. That was a very informative presentation. Dr. Praveen, you could introduce Dr. Ram, and I'll just ask one question to, because I think we are really running short of time. Does it make sense to have a thicker cap if we want to do smile on cap like as a routine, or even if you're going to do a flap on a cap? So
see, what happens is, see, if your corneal thickness is adequate, then you can have this approach. And this is what Dan Reinstein does. He has a thicker cap because he says that the anterior stromal fibers contribute more to the biomechanics. So he likes to have a thicker cap, and he uses a 135 cap, and then he uses 100 microns to do a thin flap Lasik for enhancements. But in our situation in India, generally the corneal thickness is not that good. And most of us use a 120 with micron cap thickness, and some of us even a 110 or 100 micron if we don't have adequate thickness and we are correcting a high refractive error. So in this situation, it becomes very difficult. You should not do a thin flap Lasik, because if you use a 120 micron and you have maybe like 100, you've got 100 or 110 micron, and then you have epithelial thickening also, and then you can have problems. You can enter into the interface when you're making a thin flap Lasik. So ideally, it should be 135 microns or more if you're there to use this approach.
Yes, thank you. Dr. Praveen, could you introduce the next speaker?
Yeah, I guess continuing on the theme of smile, we have Dr. Ramamurthy, who is going to be speaking to us about how you deal with a retained lenticule after smile. All of you know Dr. Ramamurthy. He's been there, done it all, so he doesn't need any introduction.
Thank you, Praveen, and thank you, ARC, for this kind invitation. So how do I deal with remnants of lenticule post-smile? A very unusual complication. I'm just going to share with you 3 case scenarios which we dealt with. This is case 1, a run-of-the-mill case, a lady who came with bilateral minus 1.5 diopters of refractive error. We thought it's just a walk in the park case. One mistake that was done is in these small errors, usually we increase the minimum lenticule thickness to 30 microns. But my optometrist who was assisting me had made a mistake and he just fed it as 10 microns. So obviously we ended up with a situation where the lenticule which needed to be taken out was extremely thin. And as you can see here, the smile procedures seem to be progressing quite routinely. And I thought everything was under control. The laser, there was nothing much to it. Usually I create a plane of cleavage anterior to the lenticule and then posterior to the lenticle. I did encounter some amount of resistance when I went posteriorly. This is the routine way of just my way of separating the anterior surface from the cap, and then posteriorly also went off routinely. It was only at the time when I was removing the lenticule. As you can see, it's an extremely thin lenticule, and I thought that it is only half the lenticule that has come out. In spite of all the experience, it does happen once in a while. Usually you are able to identify the rest of the lenticule that is over there. So I went back again and could identify a piece of the lenticule over there. And you can see me taking out the second piece of the lenticule. Unfortunately, I discarded the first half with the two segments. I thought I thought the case is over. But the problem was the next post-operative day when the patient came, very happy with the first eye, but extremely unhappy with the right eye. She had initially come with a minus 1.5 diopters, and this was the refractive error, -2 with 3.5 diopters of cylinder. And very unusually, there was a very well circumscribed bow tie, vertical bow tie that was there in the center. Obviously thought there is element of lenticule that's left over. This was in the immediate first post-operative day, and we are taken back, and you can see the incision being opened up. There was a significant amount of searching that I did. Then it struck me that somebody had suggested that you could use diluted triamcinolone acetate, and it's 1 in 5 triamcinolone acetate that I'm injecting into the lenticule. Immediately you can see over here this getting very well circumscribed. This is actually right in the center. This is the piece of lenticule that was left over. I had actually removed a piece at the bottom and superiorly, and you can see the video running. That's the lenticule being removed, and the balance of the lenticule being removed. This was on the first post-operative day. I'm sorry, the video done right. I would like to go back again. Just to show you the way initially I could not delineate the lenticule, but then once I injected triamcinolone acetate, I find that this is really helpful. Any small remnants immediately stand out, and you can see that both the confines, the superior as well as the inferior, and then so it was actually stuck on the back of the cap, and I had to scrape it off the back of the cap, and that's the piece of the lenticule being removed, which was right in the center, and that's the reason that was causing a significant residual refractive error over there, and that's the very thin lenticule remnant that's being removed. And the results were very gratifying both for me and the patient. The first post-operative day was plano 6-9. Still there you see some kind of steepness in the center which did disappear over time, and maybe because of the use of triamcinolone also, this is the first post-op day picture where the eye looks quite pristine. Going on to a second situation, this was actually a patient referred to me 1 month post-op, and you can see a significant residual error, and you can see the significant difference in the curvature, 40.5 in this side and 45 over here. And in the anterior segment OCT, there was a suggestion of a lenticule being left over, but the anterior thickness measurement was quite clinching, in the sense you could see temporally it was much more thicker compared to nasally. And this gave me an idea there is some amount of residual lenticule that's left over. And when I took a look in the slit lamp with the pupils dilated, you could see the rugosity temporally, which was not there nasally. So essentially, I went back again, and you can see this procedure here. I did not use triamcinolone acetate because I could easily identify the lenticule, and this could be removed quite simply. And by going both anterior and posterior to where I suspected the lenticule was, and it could be separated from the cap, and that's the dissection. Mind you, this was done almost a month and a half after the primary surgery had been done elsewhere, but I had enough indication to tell me that it was a remnant of a lenticule which was there left over temporally, and that's the lenticule which is being removed. And you can see that finally comes out quite, and that's being spread out and made sure, and that the rest of the lenticule had come out. And this is the first post-operative day. You can see that last of my videos, this was actually soon after we got the machine. 1 week after the primary surgery had been done. One of my colleagues had done it. He was just not able to remove the lenticule, though the laser passage had been quite adequate. And in this case, a week later, I went in. Actually, I repeated the entire process of removing the lenticule, went anteriorly, then posteriorly, and the lenticule came on out as a whole. You can see that the opening is 4 millimeters and it's fairly opened up because of the significant maneuvering that the primary surgeon had done during the first surgery. But suffice it to say that if the laser passage has been quite adequate, you can invariably identify the lenticule, remove it in toto or its remnants. Thank you so much for your kind attention.
Thank you, Dr. Ramurthy. Dr. Gitansha, you could share your thing. Just one last question. One question. If you're unable to find the remnant, what would you do?
I think you just have to wait it out. If it's not causing a problem, maybe nothing needs to be done. But if there's significant irregular astigmatism that is there, maybe 3 months down the line, once it has stabilized, we have to do a topo-guided laser treatment if sufficient corneal tissues available. Obviously, it's a difficult situation.
You can also do an open exploration. You can use the Circle software, convert it into a flap and do an open exploration.
Alternatively, if you have a IOCT, then you can also see immediately on the IOCT where the lenticule is. It's you can make out and you can take it out looking at the intraopposite microscope.
Namrata, I don't have access to IOCT, but
I'm saying if you have, then
ASOCT, I'm never able to make out very clearly. Is it very obvious in the ASOCT?
It is quite obvious in the intraopposite microscope.
Thank you. Our next speaker is Dr. Gitansha Sachdev, an essential part of this young force, which is very well informed, as we are seeing in these webinars, consultant cataract and refractive at the Eye Foundation group of hospitals. And she is going to deal on how to plan topo-guided treatments in early keratoconus. On to you, Gitansha.
Thank you. Is my screen visible?
Yes.
All right. So my talk today is on how I plan topo-guided treatment in early keratoconus. I have no financial disclosure. So topo-guided treatment with CXL essentially falls under the gamut of CXL plus, wherein alongside the cross-linking, we do a refractive procedure in order to regularize the curvature of the cornea and hence improve the refractive error post-operatively. So how does this work? Topo-guided PRK essentially entails a myopic as well as a hyperopic ablation in order to regularize the cornea. So you will have a myopic ablation at the area which corresponds to the increased curvature or the maximum area of the cone to flatten it. And there is a paracentral hyperopic band which steepens the cornea anterior to it, thereby causing surface regularization. So let's look at some of the general guidelines when it comes to planning the treatment. We know that mild to moderate cases of keratoconus are ideal indications for this treatment, but there are certain principles that one needs to keep in mind, which I will be discussing in the subsequent slides. So there have been a number of protocols that have been described, but the general consensus is that the minimum preoperative thickness, epi-on, should be around 450 microns, or the minimum thickness after the topo-guided PRK and the epithelial removal should not go below 350 microns. So on and off, that gives you around 50 microns of tissue to play with. However, there are certain publications wherein they've gone with ablations which are as deep as 80 microns, provided the preoperative corneal thickness was adequate. So at the end, you should not leave behind less than 350 microns. Here, the optic zone size can be reduced to around 5.5 millimeters in order to save some tissue. Emmetropia here is never the goal. All you're trying to do is make the cornea a little more regular in order to have better post-operative vision. Additionally, CXL here has a hyperopic shift and a refractive effect, which needs to be kept into mind. So as a general protocol, one should undercorrect for about 40% in the conventional approach, which is associated with more haze and more flattening, as against the accelerated protocol, which should have about a 20% undercorrection. So essentially one begins with correcting the higher order aberrations, then goes on to debulk as much of the cylinder as the tissue allows, going up to about 80% with the accelerated protocol. And then if there's any tissue left behind, we correct the sphere. It works both for centered as well as decentered cones, and there has been an improvement in the visual acuity and keratometry in both. However, significantly better results were found with centered cones. They've also tried this with the wavefront guided approach. The advantage would be that there would be lower ablation depth at the thinnest point. However, the challenge is that a wavefront is not repeatable. It also takes into consideration the internal abrasions along with the cornea and is dependent on things like the accommodative status and the pupil. So the tomography would give you a more repeatable scan, and obviously you could get a larger area when you're planning the treatment. So this is just a few of the examples which have undergone topo-guided treatment, where you can see there is a gross reduction in the iris asymmetry, and post-regularization there is an improvement in the corrected distance visual acuity. Now this is a centered cone where you can see more than 50% of the posterior float elevation is well within the 3 millimeter zone, and the patient has done well. Having said that, decentered cones can also do reasonably well, wherein you can see that there is a gross iris asymmetry, and this is a decentered cone. However, the patient following the treatment goes on to achieve a corrected distance visual acuity of 20/20. Just another few examples showing the corneal surface regularization and the subsequent improvement in the distance visual acuity. Centered nipple cones do exceedingly well, where you can see that there's almost no trace of the keratoconus on the curvature map postoperatively. Now, another important thing that entails discussion is the way to remove the epithelium. Now, we all know that the keratoconus has an irregular epithelium, wherein it is thicker over the depressed areas and thinner over the area of the cone. So when we do the planning, it is done with the epithelium on. However, once we remove the epithelium using either the manual or the alcohol method, the stroma that we've left
1 minute
behind
left.
with, yeah, I'm almost done. The stroma that we left behind with is grossly different from what the planning initially was. So laser ablations, which give you a uniform 50 micron ablation, would be better, because what you're left behind with underneath closely mirrors the preoperative treatment and results in better refractive and visual outcomes. There are just a couple of questions that are still unanswered. How much ectasia can we treat well? What should be the attempted correction? And can we go beyond an ablation depth of 80 microns if we have enough tissue? Also, Keratopolis has described early results of combining customized CXL with the topo-guided treatment, and the eyes have done exceedingly well. However, we will need certain more studies in order to see the how both customized CXL and topo-guided PRK with CXL work. So I just like to conclude by saying this is a promising procedure, especially for early keratoconus, and it does offer the patient a certain degree of spectacle independence post-operatively, which would not have been possible with cross-linking alone. Thank you.
Thank you, Gitansha. That was a very crisp talk. I have a question for you before we go on to our next speaker. If the corneal thickness allows, should topo-guided treatment with cross-linking be the norm, or do you see a role of doing cross-linking alone in early keratoconus?
I personally think that if the patient does not have a good best corrected spectacle visual acuity, a combination with the topo-guided PRK does exceedingly well. So if there's enough tissue, one should go on to treat as much, rebulk as much cylinder as possible, and also the sphere, and the patient would do exceedingly well.
Anything to ask Dr. Praveen before we go on to our next speaker?
Nothing specific, because I think we're running short. We'll probably move on. But nice talk, Gitansha, and would like to invite Dr. Namrata Sharma, who is another young, dynamic secretary of the Aios. So she's going to be talking to us about iatrogenic ectasia and how you manage iatrogenic ectasia. Dr. Namrata Sharma.
Thank you, Praveen, and thank you for being so kind. You're calling every speaker young. So thank you. I would be talking to you about iatrogenic ectasia, how to manage it, and I would like to thank Chitra and team ARC for this. So it can occur after refractive surgery, which we are talking about. So it can occur after PRK, Lasik, and SMILE, both, all three of them. It occurs more often after Lasik as compared to SMILE and PRK, as has been reported in literature. And basically, biomechanical corneal changes are associated with decrease in the UDBA, steepening and thinning of the cornea. And there are several criteria by which it is diagnosed, but if there's loss of best corrected visual acuity with refractive change of more than 2 diopters of spherical equivalent, topographic corneal steepening or torosity of more than 1.5, and central steepening, then we diagnose post-LASIK ectasia. The incidence in the recent times have reduced from 0.6 to 0.033%, and 50% occur in the first year, 80% occur in the second year. And as was also emphasized by Dr. Gaurav Luthra, it can occur as early as 1 week after LASIK, or even can be delayed up to several years after the initial procedure. There are absolute risk factors such as form first keratoconus and keratoconus and PMDs, and relative risk factor such as low residual bed thickness, high myopia, thin corneal pachymetry, thick LASIK flap, corneal topographical irregularity, PTA more than 40%, young age, and pregnancy. And there are 3 scoring systems which describe at risk of ectasia: the ERSS by Rendelman, the percentage tissue ablation by Santiago, and the score analyzer in OpScan. Now, it is important to note that the Rendelman risk assessment was based on the Placido disc, so the posterior elevation was not taken into consideration. And although according to Rendelman, the sensitivity is 91% and specificity is 96%, but in another study by Shan et al., it was shown that the specificity is low. It is to the tune of 56%. Likewise, PTA more than 40% is a risk factor for ectasia in normal topography. And however, most patients, when it was described, had undergone a microkeratome LASIK, and so the flap thickness was 140 microns, and no weightage was given for individual parameters such as CCT or the ablation depth. Now, in a subsequent paper by Santiago, he wanted to look at what gives more contribution to ectasia, whether it is flap thickness or it is ablation depth. It was found that flap thickness is more significant, and thick flaps were insufficient to cause ectasia in eyes with normal topography unless they are accompanied by higher ablation depths and high PTA. And so PTA more than 40% need not cause ectasia. Again, PTA more than 40% is a risk factor in suspicious topography. This again was proven in a subsequent paper by Dr. Santiago. And if we look at this paper again, this looked at the PTA, and they said that there were patients with PTA more than 40% who did not develop ectasia over a 2-year period. And again, this looked at all the 3 systems, including the score system, study done by Cordelia Chen, and score value of more than equal to 0 was the most predictive of ectasia and achieved the highest specificity. And in eyes with normal topography, use of combination of 3 system yields a greater sensitivity, but it is at the expense of specificity. So all the 3 scoring systems do have some of the other limitation. And again, in this, which is the latest paper, which looked at femtosecond laser assisted LASIK as opposed to microkeratome LASIK in the previous studies, only 4 patients, they developed post-LASIK ectasia with abnormal form first keratoconus. Now, this also said that the posterior elevation after surgery, though the change is minimal in most cases, but it makes it difficult to diagnose post-LASIK ectasia solely on the basis of the posterior elevation. If you look at the post-LASIK ectasia versus the primary corneal ectasia, the difference is that the topographic corneal steepening or torosity will be more than 1.5 diopters, and it is paracentral in keratoconus and mid-peripheral in post-LASIK ectasia. Then the Kmax value, which is 47.2, may not be there for post-LASIK ectasia because obviously these eyes have flatter corneas. Now, the management modalities are for halting the progression and for visual rehabilitation. So you can give glasses, you can give RGP contact lenses. Alternatively, minimally invasive procedures are cross-linking and intracorneal ring segments with or without cross-linking. And of course, when it is extreme, then we may have to do a corneal transplantation. This was a meta-analysis which looked at cross-linking for post-LASIK ectasia, where the UDVA remains stable with significant improvement in the CDVA, and topographic parameters, they showed less positive response to collagen cross-linking compared with the keratoconic corneas, and stabilization of the corneal thickness was observed in all the studies with a maximum follow-up of 42 months. The intracorneal ring segments are indicated whenever there is loss of the CDVA after the development of ectasia, and both single segment and double segment have been used. And this essentially, you have to give the data to the manufacturer, and they plan whether you have to use a single segment or a double segment. So these are the options which are available when you're using the intracorneal ring segments. Most studies use intracorneal ring segments followed by CXL 1 month later, and some, like at our center, you also use simultaneous ICRS with collagen cross-linking. And this is just to show the case 1, where the D value of 4.9 is seen in the right eye with the post-LASIK ectasia, the left eye 3.57. The refractive error was minimal. It was -2, -2.5. And so sometimes you cannot predict which of these cases is going to have ectasia. So we planned collagen cross-linking in this case. And this is the follow-up at 1 month post-CXL, then 3 months and 12 months. And the topography has remained almost the same and has not progressed beyond 1 year. And this is another case in which there was correction of -5 diopter sphere, and the patient had good visual acuity for 4 years, but then developed ectasia more in the left eye as compared to the right eye, and we plan to do intacs with collagen cross-linking. And in this double ring intacs was used with the Lasik flap, which was visible. And again, the D value in this case initially was 13.16. It did decrease to 10.25, and the flattening effect was also because of the presence of the intacs. So to conclude, though the scoring systems are imperfect, the incidence of post-LASIK ectasia has actually reduced to 0.03%. The characteristic pentacam findings are irregular astigmatism and central steepening. And collagen cross-linking is the treatment of choice to halt progression, although as compared to primary keratoconus, it probably doesn't work as well as in case of post-LASIK ectasia. Thank you very much for your kind attention.
Very thorough talk, Dr. Namrata. I think leaves no questions to be asked. And also because we are running out of time, any questions we could keep for the end. That was a great talk. We go on to our next speaker. Dr. Praveen, would you introduce?
Yep, the second half of the dynamic duo, Batman and Robin. So please welcome Rajesh Sinha, who is the treasurer of the Aios, who is going to be talking to us about managing haze post-PRK.
Thank you, Dr. Praveen. And I'll just share my slides. Okay. I'm sorry. I'll just share my slides.
Do you have any question for Namrata? Any of the... Okay, I think he's sharing his screen. Okay.
Okay. Sorry for the... Yeah, a very good evening to all of you. Thank you, Dr. Chitra, for having me here, and some kind words from Dr. Praveen. I'll be talking about corneal haze after surface ablation. There are ample studies in literature which states that there is some risk of haze following PRK. The subepithelial haze is seen in majority of cases. I mean, this is what these studies have shown. After PRK reaching the greatest intensity at 3 to 6 months, and then gradually decreases from there. So, but most of the studies have shown, of late, they have shown that most of the haze is, clinically insignificant. And this also includes studies wherein mitomycin C has not been used. But this is one study which states that 1/3 of patients, in spite of mitomycin C and ascorbate, they do have some degree of haze, although majority of these are clinically insignificant. But there are some cases wherein you can have a haze like this, which can have a clinical bearing. There are various risk factors like high myopic correction, more than 6 diopters. However, even the lesser corrections up to 3 diopters or 4 diopters, they can also have haze. And there are evidences and case reports in literature. Then higher correction in terms of hyperopia or astigmatism, ablation depth high, again, for the same reason. And a smaller diameter ablation profile, retreatment, previous corneal surgery, and poor ocular surface are some of the risk factors that do cause occurrence of haze. And this haze is basically because of the exaggerated corneal healing response. When there is an epithelial injury, there is a release of inflammatory mediators, and then there's keratocyte apoptosis. These activated keratocytes, they interact with these inflammatory mediators, and then they create a myelofibroblast, and these are highly reflective and less transparent, and they cause haze. And basically, it's the epithelial base membrane that is, the breach of this membrane that has been held responsible because then that can cause interaction between it exposes the keratocytes to the inflammatory mediator that is present in tear film. And another issue why higher corrections have higher chance of haze is that there can be some irregularity in higher corrections. You can have some irregularity in the surface, in the treated surface, and that can also lead to haze formation. More apoptosis, more activated keratocytes, more interaction with inflammatory mediators, more haze. There can be two types of haze. One is transitory haze, which is transient, which occurs early and then resolves after some time. And sometimes you do have a late onset corneal haze, which starts later, 2 to 5 months after surgery, and can last up to 3 years or so, and even last, a small degree of haze can even last forever. You can quantify haze objectively by confocal microscopy or shrimp fluke densitometry or ASOCT, or subjectively by slit lamp findings, depending upon the clinical details noted behind the haze. Now, this is a confocal microscopic image which shows the quantification of haze. You can see that this is the deeper endothelial side. These are the keratocytes. These are nerves which have been damaged after PRK. And this is the subepithelial area wherein you can see, highly reflective matrix material, which are myelofibroblast, which gives the idea that this is the amount of haze. As far as management of haze is concerned, prevention is done in the form of use of mitomycin C in most of the PRKs. Now, earlier people used to use mitomycin C in cases of more than correction, when correction was required for more than -3 diopters. But now there's ample evidence that even for less than 3 diopters, there are occurrences of haze. So people do use mitomycin C prophylactically in all the cases of PRK, 0.02% for variable time, but I use it for 30 seconds. This is one study which has shown that mitomycin treated eyes had minimal haze, whereas the control eyes wherein mitomycin C was not used, haze was quite significant. Similarly, there are some other studies which have shown that use of mitomycin C does prevent occurrence of haze or does prevent the severity of haze. This is a safety study, the US Army study, which states that PRK with mitomycin C for 30 seconds had no measurable levels of mitomycin C in blood, and it has systemic safety. There are some other agents like topical steroid within the first 72 hours is supposed to prevent haze formation. Now, there is a concept that majority of us, we feel that in the first 48 to 72 hours, till the time there is epithelial healing, we should not use topical steroid. That will prevent the epithelial healing. But there are a couple of studies which have shown, which have compared use of steroid in the first 72 hours and later, and they have found out that in those cases wherein steroid was used in the first 72 hours, the amount of haze was lesser for the similar amount of correction. And high dose of vitamin A, vitamin E, and vitamin C have also been advocated. Some newer modalities like plasma rich in growth factors or topical interferon alpha 2B has anti-scarring effect. Anti-TGF drug like trichostatin A. Now, a word about trichostatin A or anti-TGF drug before gene therapy. I would like to say that there are 2 isoforms. The TGF is basically for the corneal wound healing, and it has 2 isoforms, T1 and T3. T1 is more for the fibroblastic activity, like it creates more of myelofibroblast, and T3 has, when you activate T3, it inhibits fibrotic markers. So in vitro studies are being done wherein T1 stimulation is reversed by introducing T3. And there are a couple of studies which have reported some good results in vitro system. Maybe with time, you'll be able to know about it. And of course, gene therapy has also been done. If there is occurrence of haze, then as far as surgical treatment is concerned, superficial debridement with application of topical mitomycin C, followed by polishing with burr, helps in many cases. What I have seen, the diamond burr, which we normally use in most of these cases wherein, like post-pterygium surgery, polishing, even in these haze, diamond burr is quite useful. And of course, PTK with mitomycin C, 0.02% is used for removing the haze. Just a word about the duration of mitomycin C. For prophylaxis, in cases wherein you are doing a PRK and using MMC for prophylaxis, it is used for slightly lesser duration. I use it for 30 seconds. And for treating a haze, I go a little longer, and that is 45 seconds. Some studies have, used it up to 1 minute or up to 2 minutes, but I use it only for 45 seconds if I have to treat a case of haze wherein I have done PTK. Just one more point, that you can have some degree of myopia if you have a haze, significant haze. That haze causes pseudomyopia, so there's no need to treat that myopia additionally. First, the haze should be removed with PTK, and that will take care of the pseudomyopia that occurs because of haze. Thank you very much for your patient listening.
Thank you, Dr. Rajesh. That was a very thorough talk. I just have one doubt. Now, if you have haze, it's not that pseudomyopia, but there is some residual error. And it's difficult to measure the corneal thickness if there is presence of haze. So what would you do that? Would you, in such a situation, do a PRK over a PRK?
I would, if it's a significant haze, I would first remove the haze with PTK and won't correct for myopia, because if there's a significant haze, depending, I see how much is the degree of myopia. If the myopia is just -1 or even up to -1.5, I would just remove the haze and use mitomycin C, 0.02% for 45 seconds, and then see in the post-op period how it behaves.
What is the role of sunlight that you see?
Yes.
This could be very persistent. And
yes,
would you have anything for the PRK patients and sunlight?
Yes, that's a very relevant question. Yes.
Sorry?
Exposure to sunlight is also one important cause for haze occurrence. So ultraviolet.
Actually, the thing is that there are anecdotal reports. Actually, people have used chilled BSS to reduce the inflammatory activity. People also implicate sunlight because it probably increases the inflammatory activity. But there's no comparative study showing that sunlight does increase haze. I mean, there are reports, but there's no comparative study that sunlight does increase haze in cases of PR.
I had a patient who was fine for almost 3 weeks, and then following that, the haze increased phenomenally for the next 3 weeks.
Praveen, you've done so many PRKs. What is your take on it?
Yes.
I think
The duration of time which Dr. Praveen uses he uses mitomycin longer. Like I think 10 seconds for every diopter, no? That makes a difference in.
Yeah. So the number of cases we've had to retreat for haze have been, I think I remember only one case in the last 14 years or so that we had to retreat for haze after PRK. So I think it has to do with the mitomycin C duration. And like Dr. Mehta asked, the sunlight exposure is something that we emphasize. Everybody use UV protection after surgery. There actually is an observation that during the months of summer, patients tend to come back with more haze as compared to the months of winter. And there seems to be a biphasic variation there as well. So there is some correlation. And so we tell them to make sure that they protect their eyes from UV light.
Just to add to what Praveen already mentioned, what Himanshu asked, it's already well documented, something called holiday haze, where immediately after PRK, patients went on a skiing holiday, and many of them came back with haze. So there is some correlation, but not absolutely established in literature, but the incidence of haze increases once you are exposed to UV light. And that's the reason that we recommend usage of protective glasses for a longer period, like steroid drops also after PRK compared to flap Lasik.
How long the UV protective glasses?
Actually, UV rays increase apoptosis. And when there is increased apoptosis, there is greater, there's an increase in the extra cellular space. And that has been, implicated, that has been probably, suggested as probably one of the reasons why. And these activated keratocytes plus the increased swelling because of the increased extracellular space, because of increased apoptosis, because of UV rays, probably has some role to play.
Now Rajesh is speaking like a professor.
No, Rajesh was given a wonderful talk.
Last question. When
Yeah.
would you stop that enough is enough and do a PTK?
In a haze?
Yes. 3 months, 6 months. When would you decide that now enough is enough? Steroids are not working. The haze is increasing, and I'll do PTK now. What's your cutoff factor?
I think 6 months.
Dr. Praveen, anything?
Praveen?
He has no experience. He says he doesn't have haze in his session.
I didn't say that. I said somebody who requires retreatment. I think only one we had to do.
Actually, it's so variable because many of these patients are referred. Many of the patients are referred. So it's so variable time that,
So Praveen, what is your secret of success? You have no haze.
Yeah.
It's no mitomycin.
How much?
What? 10 seconds per diopter.
Sorry?
10 seconds for
10 seconds per diopter.
And I think he would correct even up to beyond 8, I think, no? If the corneal thickness allows.
I think
in the beginning, 9.
There is an anecdotal patient that Praveen likes to talk about, and in the end, he discloses who that patient is.
But I think paucity of time, we are going to go on to our next speaker. Next speaker is none other than my very efficient co-moderator, Dr. Praveen Krishna, who is going to talk on phakic IOLs in keratoconus.
Thanks, Chitra, and thanks to everyone for the wonderful discussion, and thanks to the ARC and especially to Chitra for having me on this panel. So I'm going to be speaking in the next 5 minutes or so about phakic IOLs in keratoconus, and the questions that I hope to answer in the next 5 minutes would be, do phakic IOLs actually work for patients who have keratoconus? What kind of keratoconus do they work best in? How is planning for phakic IOLs different in keratoconus from a routine patient? And a little bit about the outcomes of these surgeries. So typically, if you look at the surgical options for a patient who has keratoconus, they're divided into either stabilizing surgeries or vision correction surgeries. So stabilizing, of course, is collagen cross-linking. Vision correction, you can broadly divide them into implants and transplants. And among implants is where phakic IOL actually fits in. And of course, we're not going to be talking about the other kinds of surgery today. So a little bit of literature just to drive home the point about whether phakic IOLs work for keratoconus or not, and what kind of keratoconus they work in. Most case series that are available that are published are small case series, less than 20 patients. And that itself will tell you that this is not a very commonly performed procedure. But if you look at the corrected distance visual acuity of patients who have undergone phakic IOLs in patients who have keratoconus, all of these actually are patients who have relatively good spectacle corrected visual acuity. And if you look at the refraction, most of them are people who have very high myopia and relatively lower astigmatism if you consider that all of these are keratoconus patients. If you also look at the uncorrected distance visual acuity of patients, you'll also notice that all of them are not 20/20, but they probably mirror the kind of visual acuity they had with spectacles before surgery. And if you look at the topography K readings, you'll see that most of these are mild to moderate keratoconus and not severe keratoconus. That was about the artisan phakic lenses. There also are smaller case series with the posterior chamber phakic IOLs like the ICL, and the accuracy of these lenses, if you will see, seem to be a little lesser in keratoconus as you would expect compared to normal patients. But what is also important is the fact that these tend to be quite stable. The refractive error is quite stable over a 3-year period. But digging a little deeper into all of this is if you look at the kind of patients that have been operated. The average age of patients operated for an ICL are patients who are closer to 40 years, patients who have a higher spherical equivalent and a relatively lower cylinder again for a keratoconus patient, and patients where the best spectacle corrected visual acuity is actually very good. So that's the typical patient who seems to do very well with a phakic IOL. And also, if you look at the mean K readings, you'll see that the highest K reading in this series was 52 diopters. So again, mild to moderate keratoconus. And if you look at the central corneal thickness, 500 microns again, which also tells you that this is not advanced keratoconus. Which kind of phakic IOL? It seems that the iris claw as well as the posterior chamber IOLs tend to do equally well in cases of keratoconus, with the posterior chamber IOLs doing a slightly better job than the iris claw lenses. So what are the variables that will be different in a patient with keratoconus compared to a normal patient? The 5 variables that we typically pay attention to in anybody whom we are planning phakic IOL calculations. Number 1 is the refraction. Well, what is interesting to see that is in patients with keratoconus, the variability in refraction, if you do refraction 2 times by the same person, is extremely high. And so that is another problem, because this is what you're basing the ordering of the power of your phakic IOL on. So you can expect greater variability in the outcomes because of the fact that the measured refraction by itself, both sphere as well as cylinder, tends to be more variable in keratoconus patients. Keratometry, again, though not of fundamental importance in phakic IOL planning and calculations, is important to also know and correlate the kind of cylinder that you have. And if you have an eccentric cone because it is measured in the center, again, this could be erroneous. What is interesting is the anterior chamber depth measurements. And here is a very nice example that will show you that in patients with keratoconus, typically the anterior chamber depth in the center is deeper because of the cone. But this does not reflect the depth of the peripheral anterior chamber. So in patients who have normal eyes without keratoconus, the depth of the central anterior chamber tends to sort of be a surrogate measure for the depth of the peripheral anterior chamber as well, which tends to be deeper, especially in myopes. So if you do a phakic IOL using the regular calculations in a keratoconus patients, it is more likely that you will end up with a shallower anterior chamber and a higher vault as compared to a normal patient. Again, I don't have evidence to show this, but this is an anecdotal observation amongst the series of keratoconus patients that we have. The other important thing is the white to white distance probably doesn't really matter here, but in some patients who had allergy and limbal papillae, taking the measurements from your automatic tools like your OBSCAN will be erroneous. So it's always important to ensure that you measure manually as well. And the last variable is the endothelial cell count. Again, what is interesting is keratoconus patients typically tend to have a lower endothelial cell count than normal patients. And this tends to become lower and lower as the severity of the keratoconus increases as well, because endothelial cells have a larger surface area to cover in a patient who has ectasia. So a case example, this is a 35-year-old lady whom we followed for 5 years, who had stable topography and refraction, minus 13, minus 1.5, minus 14, minus 3. And she underwent a phakic IOL post-op 1 month. She did very well with a slight residual error of a minus 1.25 cylinder in both eyes, 20/25, and she was quite happy. As you can see, the vault is a little higher than what you would expect in a normal ICL patient. Post-op 1 year, she is also stable again with the visual acuity as well as the best corrected vision maintained with a slight drop in the left eye. We've looked at our data and we have about 19 eyes of patients who underwent ICL or any other phakic IOL for keratoconus with a mean age of around 30 years. So you see that this is an older subgroup of patients who tend to be more stable. Average pre-op sphere is minus 11. Average pre-op cylinder was minus 2. And you'll see again, this also shows you that most patients are patients with central cones or patients who have a mild to moderate keratoconus. So to summarize, what we found in patients who have keratoconus who undergo a phakic IOL, ensure that you explain that the patient is going to have a larger residual error range and not to expect uncorrected visual acuity of 20/20 or even no refractive error after surgery. Ensure that you look for stable refraction and keratometry. This could be variable depending on the age of the patient and the kind of keratoconus, but what is suggested in literature is 2 years. 2 years is a very long time, and probably 6 months to 1 year probably would be a more rational time that you look for stability. Ensure that you have good spectacle corrected visual acuity, because visual acuity with the contact lens is never going to be replicated by a phakic IOL in the eye. And also explain to the patient that they will get what they are seeing with spectacles or maybe just one line better than that. Always try to limit this to mild to moderate keratoconus, because predictability goes down as your K becomes higher and as your cornea becomes more eccentric as well. And if you have a patient who's progressing, ensure that you do a collagen cross-linking to stabilize the keratometry on the cornea Once you're happy with the stability, you can go ahead with a phakic IOL. The other thing that is also helpful is to combine procedures, combine and use an intracorneal ring segment to improve best spectacle corrected visual acuity before you plan a phakic IOL. And the ideal time between these two procedures should be at least about 6 months. Thank you very much.
Thank you very much, Dr. Praveen. That was a very good talk. Anybody in the panel have a question for him?
Just one point I would like to add that, what Praveen told, the last point, the combining ICRS, some of the keratoconus patients, what I have experienced, a few of the patients who had high astigmatism. So I've used a single segment of intracorneal ring segment to reduce the astigmatism. And then I've gone with I'm combined CXL with the ICRS, and then later on, after 6 months, went ahead with the ICL. So in those cases, it is good to combine, but most of these keratoconus cases have high astigmatism, so a single segment will be a good option in such cases.
I would just like to emphasize a point which Praveen already made, in the sense that if you don't have tools to all this and don't understand everything, please go purely by spectacle corrected visual acuity, because your ICL or phakic intraocular lens is only going to correct refractive error. It's not going to do anything to corneal aberrations or corneal irregularity. So if they are happy with their spectacles, please go ahead and try phakic intraocular lenses. But if they need contact lenses, rigid gas permeable or rose-scale lenses for scleral lenses for correcting their refractive error, then they are not good candidates for phakic intraocular lenses.
Thank you.
I just had one point that basically how long, see, Praveen says you can wait up till 2 years, but many of these patients, after cross-linking, they have a lot of disability in the sense that they have to wear the contact lenses. With the glasses, the vision is not, again, good, or they have a very high power. So I generally wait for 3 to 6 months and then do the ICL, because after that, the change is not much. Because if you keep waiting, sometimes you have progressive flattening also, and the flattening can occur even up till 6 years, 7 years. So the refraction again keeps changing in keratoconus. So every time a person refracts, there is a little bit of variation, and it is difficult to get an accurate refraction also with keratoconus. So these are the problems, and generally the patients want to overcome their disability of the high refraction. So 3 to 6 months, but I tell them that there can be mild changes, but they're okay with it.
Please, also a difference.
Paucity of time, I'm going to go on to the next speaker. And the Kumar doctor had got missed out, so he'll be our next speaker. Dr. Kumar, you could share your video. He's the chairman and MD of the Kumar Doctor Eye Hospital, and a versatile surgeon whom we all know, who's going to take us back to an earlier step, reiterate the superiority of phakic IOLs, that they are better than corneal procedures. On to you, Kumar. Are you muted?
Okay. So you can see this?
Yes,
now
we
you can hear me?
Yeah.
Thanks, Chitra, for this opportunity, and congratulations for a fantastic show. I think Dr. Praveen made my life a little simpler since he spoke before me, but this was an article as in March 2020, where they've said that the iris claw phakic IOLs have excellent outcomes even in corneal ectasia. So this is what I think he was talking about, and these are giving excellent results. But if you look back at 2008, surprisingly, long-term use of the artificial lens said that there was endothelial cell loss. So it was not doing so well then, because the lens design has changed, everything is done. We have used varices phakic IOLs many years back, and they gave excellent results in high myopia. So this was documented then. So these are the two phakic IOLs which are the most popular ones which are used. One is the iris clip IOL and the star, or any of the phakic IOLs which are posterior, placed in front of our normal natural lens. There was another article on phakic IOLs which said that this did well, but as far as the toricity was concerned, it was not very stable, and that's the reason why they tend to rotate. And then came the perfection of sizing. Sizing was the most important thing where the mistake was being done. So here comes the next article about why phakic IOLs, and this was saying that in severe myopia, it gave much better predictable visual outcome than laser refractive surgery. So this was one more thing that was produced out in 2000, and this was about in 2016. Coming to the American Academy, Stephen Lane believes that phakic IOL is the way to go, and this is not a very old article. And he said that this is a much safer prospective procedure. The main thing being that Lasik is all about subtraction. We know this, right? So we are removing tissue. While phakic IOLs do not carry inherent problems of corneal surgery. So we are adding a lens, okay? So we are not disturbing the other optical system at all. So we are not disturbing the cornea, we're not disturbing the natural lens, and we are adding a lens. So actually it aids and it really helps our patients. So this was again a report by Stephen Lane as far as the American Academy was concerned. Then came the posterior chamber phakic IOLs, and here they said the treatment was much better for high myopia. Initially, if you remember, we used to do phakic IOLs for very high myopia of more than minus 12, 13, and 14. Now that came down to 10, and then it further came down to, and some of us use phakic IOLs for more than minus 8. And of course, we know that the biggest advantage of phakic IOL is the reversibility, immediate correction, which we know, stability, and relative simplicity. A lot of techniques of phakic IOLs have changed over time. Previously, for example, in star ICL, I used to use methyl cellulose, and now the new thing that we are doing is we can put the ICL just under irrigation, and we really don't need to put pilocarpine to constrict the pupil, and this itself made the stability, and no need to remove methyl cellulose, no fear of the IOP going up, etc. Again, phakic IOL in tough cases, as rightly pointed out by Dr. Praveen Krishnan, that it can be used in patients who undergone C3R. So I've used this in patients who had intacs with C3R. The biggest advantage of intacs is that it centralizes the cone. Once it centralizes the cone, we can go ahead and do the phakic IOL, of course, knowing that the chamber is deep enough to take a phakic IOL, and this gave excellent results. You have to wait for the X amount of time, and that would give very, very good results. There was another study by Nasir which said about phakic IOLs, and this was almost 69 eyes for 46 patients, and ranging from as little as myopia of 3 to 25. And this gave excellent results. So myopia as little as 3 also was attempted with a phakic IOL at that time and gave excellent results. Coming to phakic IOLs and surface treatment. Now we all know, as rightly mentioned by Dr. Rajesh Sinha, that surface treatments can lead to haze. Phakic IOLs is a lenticular path, we know this. No issue of knowing a vitamin D, no question of post-op period of recovery, no issue of faster visual recovery, no question of wound healing, no question of apoptosis. So all that is taken care of when it comes to phakic IOLs and surface treatment. So comparatively, we know that surface treatments now with the new smart pulse treatment, the recovery is much faster compared to the older 4 days. Now it's almost 2 days, the pain is almost gone. But it has an element of a question mark in some patients. And of course, as mentioned, that ultraviolet light and exposure to UV light and the holiday haze can also happen in this case, which nothing of this type will happen in phakic IOLs. Some studies had talked of rotation of IOLs, the phakic IOLs, and that's why the most important thing that has come in now is about sizing. So the sizing now is much better. We have a big choice of Indian phakic IOLs. The star ICLs are also available. The 2 companies from India, the IOCare and the Biotech, are also available. Another study from Academy where you will be surprised, ever since phakic IOLs have become FDA approved, and there was one article which mentioned that it devoted almost 12 out of 45 chapters to phakic IOLs. But of course, this was in 2008. That is when phakic IOLs actually picked up 2007 edition, where textbooks started writing more about phakic IOLs after it got FDA approval, and so many chapters were mentioned about it. This is as past as Academy 2020. There is a comparison between toric Collamer IOL and a toric artifact phakic IOL and visual outcomes. And they have shown promising results in terms of safety, efficacy, predictability, and correction of myopic astigmatism. So phakic IOLs, we know now can even do toric corrections. They have been doing toric corrections, but even the iris claw phakic IOL can do a toric correction. And this has been shown in a paired study, identical. These lenses were clinically superior to any other lens that was found. This is as past as the American Academy study. So this is the toric phakic IOL that is now also available in the market. We also know that the star toric IOL is also available in the market. So lots of Indian companies are nowadays making phakic IOLs too, but not enough published data is found on this as far as my knowledge goes, but of course all of you can add to this. So what is the advantage that I find in a summary? No cutting of cornea, so all the benefits of no striae, microstriae, macrostriae, no free caps, all that is gone. No upside down caps, everything is gone. The question of dryness is sorted out completely. No ectasia, that's one biggest benefit is there, so you're not touching the cornea at all. And no issue of quality. You know, some of our patients do have 6/6 vision, they've undergone perfect smile, they've undergone perfect LASIK, and yet some of them do complain that they're not very happy with the quality of vision. So here, the biggest advantage is completely reversible. Up till now, of course, I have explanted one phakic IOL, which was the first design of the star. Now is the fourth edition where the central hole has appeared. And that time it was much thicker, much bigger in size, and we had to explant it because of glaucoma. So the advantage in phakic IOL, I feel, is reversible. Cost is an issue if you get the phakic IOLs from abroad, but Indian phakic IOLs, you know that the cost is not that much of an issue. And application of these IOLs after cross-linking, as likely mentioned by Dr. Praveen. So replacing LASIK, I think for thinner corneas, now our cutoff is much better, thinner corneas. So if your cornea is thin and your anterior chamber is good enough, higher refractive errors for more than -8. Complex cases, if you do intacts with C3R, and if your cone is central, you can still go ahead and put a phakic IOL. With the central hole, all the other complications have actually gone. So in summary, yes, this option is quite possible and quite available for our patients.
Thank you very much, Kumar. You are so eloquent. I have 2-3 rapid questions for you. Would you sell your eczema and shift to phakic IOLs altogether? Number one. Number two is, do we have studies who have said that after central flow coming in, the incidence of cataract has totally gone? And the third question is, with the lens rise, which is being much discussed now, do you think there will be increased vaulting of phakic IOLs later?
So the first question is, I will not sell my eczema. The second question is about vaulting, and I said actually the central flow is more for glaucoma and not for cataract. So the prevention of glaucoma, and because I think Gaurav started this technique of putting irrigation, not putting methylcellulose at all in the anterior chamber. So the question of your central flow getting blocked by methylcellulose is completely gone, and that's the biggest benefit that we get. So you can inject the ICL just under saline, and you don't really need methylcellulose. As far as vaulting is concerned, yes, we have to look at the vault post-operatively in all the cases. But now I think with better size understanding, with electronic calipers, with OpScan, and all those comparison data, the sizing is a little better. So now, in fact, last few months or few years, whatever we are seeing, the sizing is really sorted out. Once in a while, you may get a high vault, but otherwise it's not needing to an explantation. So that's not where we have reached. All of you may have more data, but this is what I have found in my clinical data.
Kumar, regarding your question about comparing the Indian lenses with the Visian, we recently did a study, an in-depth study, and it is in print now in the JRS. It's been accepted in the JRS, and we found that there is not much of difference. And even the Indian lenses with Biotech, they perform very well.
So you compared with Biotech or IOCare?
Biotech. This was a comparative study with Biotech.
I've done a comparative study with RIL of Appasamy and ICL, and most of the parameters were almost the same. Only the MTF was better. MTF on eye trace was better in ICL. Rest of the things were absolutely comparable.
Dr. Praveen, could you introduce the next speaker? Thanks, Kumar.
Thank you, Chitra.
Well, I've been introducing a lot of people saying that they were young, but now this next speaker is truly young in all aspects.
You didn't call me young. Praveen, I have an objection.
You make everybody feel
I didn't introduce you, Kumar, so you missed out. Well, you know what I think. Anyways, so we have Natasha Pahuja, who's going to be speaking up to us about dry eye and LASIK surgery. It's been subject to a lot of discussions that we've had since the last 2 hours. So hopefully she'll clear up a few things for us.
Thank you, Dr. Praveen, for that kind introduction. And thank you, ARC and Dr. Chitra, for this humbling opportunity. Hopefully in the next 5 minutes, I'll do justice to one of the most common complications or side effects, as we call it, of refractive surgery, especially LASIK. Now, this was a WhatsApp consultation I had done for a colleague of mine. She sent me this image, a Placido image, and she said that after 3 months, the patient has come to me with no change in refraction, but the quality of vision and the lines have reduced. And she said, do you think it's post-LASIK ectasia? Because of lack of elevation data and epithelial mapping, I asked her, could you just send me a clinical image so that we can see the surface? And this is what we found. We found that the patient had severe dry eye disease. She had SPKs on the surface. So this is a very, very relevant topic, simply because more than half of our patients at the end of 6 months are suffering from or are not able to get the full benefit of LASIK simply because they're suffering from dry eye-like symptoms. Now, how do we deal with dry eye disease? It's actually very simple and it's stepwise. But most importantly, the first step is planning well, which is preoperative planning, also the intraoperative choices that we make, and how do we deal with it post-operatively. Let's take it step by step. Preoperative, the first thing that we do is when a patient walks in and is interested in LASIK or refractive surgery, we give this questionnaire. Well, there are multiple questionnaires available. I personally use the OSDI and the SPEED questionnaire. It helps me decide if the patient needs a detailed examination and a detailed dry eye evaluation. So this is what the patient is further subjected to while the patient is, before the patient comes and sees me, even before the patient undergoes refraction. After getting a detailed dry eye assessment done, which includes getting the functional assessment, that means looking at the quality of the tear film, as well as the structure. Now, the quality can be determined by keratograph and the tear film interferometry. The anatomy or the meibomian gland structure can be determined by meibography, and there are various tools available to do it. So in a clinic, stepwise, what we do is plan it beforehand, see the patient very well, take a detailed history, and it has been done in this order. So after the questionnaires are determined, after which we see the patient on slit lamp without disrupting the ocular surface, the first thing that is done is the non-invasive diagnostic modalities, and then looking at the tear film composition in terms of osmolarity or checking the MMP9, after which we touch the ocular surface by doing either Schirmer's or T-Butt or staining the ocular surface. Further, we do a systemic workup for all our patients. And if we have the luxury of advanced diagnostics, we do look at the confocal microscopy and tear biomarkers. So essentially, it helps us decide in this multimodal disease as to where we stand. And especially if the patient falls into the evaporative or the mixed type of dry eye disease, we do treat these patients preoperatively. Now, I've started doing IRPL for my patients. First 2 sittings go before they are considered for refractive surgery. And if the patient has got enough meibomian glands, I do consider doing the thermal pulsation as well. So after the patient is primed beforehand, then I consider refractive surgery. Now, the considerations that happen intraoperatively primarily is just one, which is deciding what kind of refractive surgery would you choose if a patient has already dry eye disease. Now, we know that there are denervation methods that happen. The less denervating methodology would be with the SMILE. Why is it so important is because the nerves on the cornea maintain the ocular surface homeostasis, which was also discussed earlier. And it is responsible for a lot of ocular surface disease pathophysiologies. So what we have documented is, and it has been published to death, that LASIK causes significant denervation immediately post-surgery, and it takes a few years for the nerves to grow back. So this was just me experimenting a little on one of the SMILE patients, and it was very encouraging to see that the nerves started regenerating 6 months post-surgery, which was very, very hopeful. And this also probably explains why the patients post-SMILE have less dry eye-like symptoms. And what was other factor that helps us decide is now the questionnaire that we ask the patient to fill up beforehand. This translated into a study that we saw that patients who had significant higher OSDI also had changes on the corneal nerves, as well as had increased dendritic cells. Now, this is a simple surrogate marker. You don't need a confocal microscopy to decide this. Now, if a patient has higher OSDI, we know that the patient is prone to have more changes post-denervation. Now, how did we translate this? Is that we started looking at the OSDI more in detail, and the patients who had higher OSDI, these patients, before they're picked up for refractive surgery, undergo vitamin D treatment. Now, this has been published to death again. We have looked at the role of vitamin D and dry eye disease, and it has seen in a clinical translation, we see that the patients do much better with vitamin D treatment preoperatively. Now, here's another perspective. While I was preparing this presentation, I came across patients, the neuroprotective role of citicoline, which has shown that instilling the drop 3 times a day has shown that the corneal sensitivity improves as early as 1 week, as opposed to the control group, which took about 3 weeks for the corneal sensations to come back post-Lasik. Now, this seemed quite encouraging, and I hopefully look forward to try this out in the clinic. While we are still waiting for it, and if you still decide to take the patient up for Lasik, here are some things that we would want to look at. These are patients who are at higher risk of developing post-Lasik dry eye disease. Asian race and female sex are known to have more dry eye disease. Other risk factors are higher refractive correction and higher ablation depth or thicker caps. The modification that we can do intraoperatively is that we can have wider flap hinges and probably place the flap hinge nasally rather than placing it superiorly if it suits your surgical style. These are certain factors which will help us decrease the incidence of dry eye disease post refractive surgery. Now, coming to managing post-operatively, how do we do it? Now, these are the possible mechanisms, and I just made a flow chart of it. The ideal way would be to tackle one of them. Now we know that there is decreased corneal sensitivity. So there is increased inflammation, because of which there is increased hyperosmolarity because the tear secretion has decreased. And there is increased apoptosis because of the ocular surface damage. Now, why not target these specific possible mechanisms? So what we do is essentially have post-operative medications that are targeting these specific etiopathogenesis of dry eye disease. For instance, for immunomodulation, we put the patients on cyclosporin for a longer time. The other promising drug is Zidra, which is yet to come into the Indian market. Autophagy induction would be very helpful, and this can be done by tear substitutes simply, Trehalose being one of them. And osmoprotective agents as tear substitutes would be very, very encouraging post-refractive surgery, post-Lasik. Other factors which can help decrease the incidence of dry eye disease is we know that meibomian glands do get affected in evaporative dry eye disease. So it would be important to tackle this post-operatively if the patient does develop dry eye symptoms, especially evaporative dry eye symptoms. So considering LipiFlow or in IRPL would be ideal to treat post-operative dry eye disease. Now, this is my cousin. He had a loss of meibomian glands. So I did I had done IPL for him, and it was very encouraging to see certain meibomian glands coming back. I have absolutely no explanation why this happened. But after this, I did his refractive surgery, and he was very, very happy. So essentially, to sum up, this is my post-operative medication treatment modality that goes on. They have an exhaustive list that the patients are put at least for 6 months. So to summarize, it is important that we prepare well. It would be important that we do certain modifications for our patients to not develop severe dry eye-like symptoms, and most importantly, to choose our lubricants post-operatively that will reduce the incidence and the feeling or the sensations of dry eye-like symptoms that the patients experience. Thank you very much for your attention.
That was a wonderful talk, Natasha, wonderful. So much of information, and we didn't even have to give you warning at all that you were running late. That's the youngsters for us.
I just have one question, Natasha. The first case which you showed was very interesting, the topography.
Yes, sir.
So what did you do for that patient?
Actually, the patient was put on sodium hyaluronate, tear substitutes. I'm yet to see. This was a WhatsApp consultation that I did for a colleague. She sent me a Placido image. So I put her on sodium hyaluronate and gel-based formulations, and I'm yet to get a report back.
Okay, if you look at the topography, this is a very typical case. If you look at the topography and the staining pattern, this is a typical case of nocturnal lagophthalmos, and we see many of
Absolutely.
these patients who have a band of the SPK inferiorly. And if you look at the topography also, the topography pattern is typical of nocturnal lagophthalmos. And many a
Absolutely.
time we are looking at all other things, but we miss the lids. And what I tell the attendants is to observe these patients when they sleep at night, and then they don't close their eyes fully. So putting them on a gel at night and taping the lids, that improves their topography, and then the corneas clear up after a couple of days.
Yes. Absolutely. I should have mentioned earlier, sir. I just asked her to put those iPads. I said, and when you use it in the airplane, just try and sleep with that. So probably it will be helpful. She was happy with it, but as I said, I'm yet to get a report back from the referring surgeon.
But that is typical. I mean, if you look at the topography
Absolutely.
and the staining pattern,
Yes.
SPK, it's typical.
That was a very good observation, Sri Ganesh. We shall now go on to our last speaker, member ARC West, a very dynamic person from Mumbai, who's going to tell us actually on the most quintessential issue, the essential pre-op workup for refractive surgery. On to you, Anaga.
Thank you so much, ma'am. And thank you so much for this opportunity. I'll just share my screen. Is my screen visible, ma'am? And am I audible clearly?
Yes.
Yeah. Thank you for giving me this opportunity on speaking on my take on essential preoperative workups in refractive surgery. In today's day of improving technologies and increasing confidence, we promise the world to our LASIK patients. But we need to remember that in order to get the best visual outcomes, we not only need to have a proper case selection and workup, but also precise surgical technique, good counseling, and excellent post-operative care. Yes, the proper workup of the patient begins right from the proper history and the age of the patient, a complete good clinical examination of the patient, and yes, the most important part is the refractive surgery workup, which includes the topography, aberrometry, pachymetry, tomography, and yes, today we have this epithelial mapping, dry eye evaluation, serum vitamin D, and in those cases where we are planning to probably use a phakic IOL instead of LASIK, then the anterior chamber depth and the white to white measurement. Definitely, we need to also rule out the systemic contraindications to prevent any further complications. And we in our center, and definitely everyone would be having some kind of a LASIK workup sheet where you not only have all the complete details of about the personal data about the patient, the ophthalmic history, as well as all the other parameters regarding the clinical evaluation and the parameters and details of the flap that we have would be doing in the intraoperative period and any events that may have happened. Needless to say, because it's a refractive surgery, the refraction has to be bang on target, and we need to look for refractive stability. Also go in and look for other old prescriptions and old glasses of the patient. Definitely cycloplegic refraction is extremely important, especially in hyperopic patients. And in those patients who are low myopes and in the pre-presbyopic age groups, it's better not to push them too much for LASIK because they already have good vision for near without glasses. Those patients who have a history of chronic contact lens wear may have peripheral neovascularization like this, which can bleed on table, and we need to be careful about it. Or they may have evidence of prior contact lens related corneal infections, and these spots could be an indication that they have these kind of infections earlier. Again, contact lenses need to be stopped at least a week before the surgery, and in case of RGP and toric, at least around 3 weeks before the surgery. Many patients could have corneal warpage like this, and they need to be stopped and look for repeated topography till the topography actually stabilizes. A detailed slit lamp examination, especially for ocular surface, is important. Rule out problems like meibomian gland dysfunction, blepharitis, and corneal dot opacities like this, which may have had probably because of an old adenoviral conjunctivitis also, and this could probably hinder a femtolaser during surgery. Even sometimes things like a pincilla can actually probably come in the way of suction during a microkeratome lacing. Definitely, we cannot overemphasize the need for a proper retinal evaluation of the periphery and need for laser treatment wherever it is required. Like Dr. Natasha mentioned, we have a dry eye evaluation definitely for all our patients, including the OSDI score, the mybography, T-Shermer's test, including all the other tests also that she mentioned. And many times in our practice also, we have used the IPL treatment that we are having access to. for many of these patients and stabilize the ocular surface before taking up the patient apart from the medical management. It's not just the preoperative care, but also the predictive care post LASIK that is also important. We need to avoid excessive flattening and excessive steepening of the cornea in order to prevent any night vision issues. And yes, anticipate flap complications in cases of very flat corneas or very steep corneas. Definitely the ectasia risk factor scoring system by Randleman comes in handy, and we need to remember to keep at least 300 microns in the residual stromal bed. Be very wary of corneas that are less than 500 microns. And definitely in case of very high myopes, it would be prudent to go in for a phakic IOL rather than go ahead with LASIK. PTA already Dr. Namrata Madam has alluded to, and this definitely we keep less than 40%. There are times where you may have a mild to moderate myopia with a good pachy and you may be tempted to go in. There are many other centers in the periphery or in the rural areas where they may not have had access to tomography. But even with a basic topography, we need to look for red flags like this in inferior steepening like this. And sometimes even the pathfinder can give you very, very small points like a difference in the inferior superior keratometric value of more than 1.4 or a vertical coma, or even if the patient is not actually accepting the entire cylinder that is in the manifest refraction, that could be a red flag. Definitely tomography has to be very, very important and is the most critical part of the workup. I've been using the Pentacam. You may also use the Sirius or the Galili, whichever you have access to. It gives you the sagittal curvatures and the front and the back elevation and the global pachymetry map, which is so essential. The other factors that can be or could be red flags are the SRAX, which may be more than 22 degrees. Look for the thinnest pachymetry, not be less than 480. The Y coordinate of the thinnest location, and if there's a difference between the topographic and manifest astigmatism of more than 15 degrees or more than 1 diopters, it could be a red flag. Also a superior inferior difference in 30 microns or the posterior corneal elevation of more than 18 microns should be a red flag. The BAD-D display is very easy to read because of the color coding. So the exclusion map as well as the difference map inferiorly gives you a very good indication of early ectasia. And here, definitely these are gross indicators. The CTSP and the PTI curves also should be looked at. And if there is a deviation from the normal, it has to be considered as keratoconus. And look for all the high risk and the moderate risks. Also, the inter-eye corneal symmetry has to be looked at. And definitely these cases should not be taken up for LASIK. Integration of the biomechanical assessment along with the tomography is important. So you have the CBI as well as the TBI index, and the combination of these two will definitely help in detecting ectasia in all these patients. Epithelial mapping for subclinical keratoconus has been used nowadays, and you can see it by seeing that there is a change in the epithelial map, thinning at the tip of the cone and thickening in the periphery. OSD also, you can see the epithelial mapping. There is a classification of the type of dry eye. And in cases of especially PRK, where you can actually see the change in the epithelial map as the patient recovers in the next few months. Pupillometry can be done to decide the optimum optic zone size, and in very large pupils, it could probably indicate that the patient would have greater dysphotopsia post-treatment. Angle kappa is so important, especially in hyperopic treatments. And in these cases, you need to actually center the treatment on the corneal vertex. Counseling plays a very, very important role. Give them realistic expectations and a brief about the potential complications and various other options as and when required. For example, one of these patients had borderline pachy of 500, and in the one in the right eye had a very high myopia. We did a phakic IOL in the right eye, and this is the post-LASIK topography in the left eye, which shows the central ablation. What I want to tell here is this is the post-surgical aberrometry, and it shows that the higher order aberrations are comparable. And last but not the least, prevent related errors, ensure that correct data is fed, good fluence test, and explain the procedure to the patient. So to conclude, the keys to success is refractive surgery is all about more and more care. Thank you so much for your kind attention.
That was wonderful, Anaga. I think you just covered everything in that 5 minutes, everything which was necessary, and it was very enjoyable hearing you. Are there any questions before we conclude? Dr. Praveen?
At least from the audience panel, looks like there are no more questions that are pending.
Oh, good. So I think I'll conclude then. I'm sure all of us know it's been one amazing webinar with so many stalwarts and their thoughts, which has been of great relevance. My very special thanks to every dear expert panel we've been lucky to have amidst us. Our charged, fantastic set of speakers, an outstanding co-moderator to run the show, Dr. Praveen, our admin team headed by Kripal, our ever helpful Mr. Sunil, who's the webinar admin, Sai and Manjula from Numerotech, who have always been there with their great guidance and support, my very strong ARC team, Mr. Nikhil and Mr. Raman from Entode, for their steadfast commitment to sponsor every single event of ARC, and one and all of you who are still remaining in this dear audience, because it's your presence which encourages us to take steps forward with great energy each time. Thank you, one and all of you. Thank you.
Thank you, Chitra.
Thank you
very
so
nice
much.
session. Thank you, everybody.
Very nice. Everybody spoke so well.
Thank you
It
very
was
much.
very nice.
Thank you.
Thank you so
Thanks to
much.
the
Thanks,
participants
Rajesh.
for
Thank you.
putting this
Good night.
together. Really good job.
Thank-
I'm really
yeah.
like
Excellent job, I
Thanks,
think, Dr.
Praveen.
Chitra and Praveen. What a fantastic webinar. It'll be a huge resource for anybody who wants to learn refractive surgery.
Yeah,
Yeah, it
exactly.
will be available on
Absolutely.
YouTube, no?
No, you
It
know,
will be
I'm not,
available on YouTube.
no, we are uploading everything onto the ARC website also.
ARC website.
So every
We like YouTube
program
better, actually.
Yeah,
Oh,
YouTube, the accessibility is
I'm just
better.
joking.
yeah.
Great. Congratulations, Praveen. Congratulations.
Congratulations.